disabled participant screen sharing and baratte sir.
Screen share enable ಮಾಡಿ screen share ಮಾಡ್ತಾರೆ.
Okay.
You try madam share ಮಾಡ್ರಿ.
Yes sir. Is it?
Okay.
Thank you sir.
Praveen sir, Pradeep sir ಕೇಳೋಣ ಇದರ network on and off ಇಲ್ರಿ thanks sir nursing ಯಾರು ಸರಿ Praveen wants to start this. Now,
Good morning, one and all. I welcome you all to this academic program conducted by Department of Pediatrics, BLDE deemed to be University, Shri Patil Medical College. We are back with another academic event. We are discussing about neonatal sepsis. This event is conducted on the occasion of Hand Hygiene Advocacy Week, celebrated every year in the month of October. Global Hand Hygiene Day is celebrated on October 15th every year. I welcome you all to the program. Now I request Dr. Sidhu Chakki sir to take over and start our academic event.
Good morning all, respected seniors and my friends. We are conducting this webinar about a hybrid CME, what we call it as, on the eve of World Hand Hygiene Advocacy Week. October 15th is celebrated as Hand Hygiene Day. So we thought we'll discuss something important about the hand hygiene practices and the sepsis being prevalent in our part of Karnataka. And now I call upon Dr. Anita Namgoda ma'am to start with the first lecture. Madam needs no introduction. Thank you ma'am for agreeing to deliver a lecture at a very short notice, 2 days back. And I know it's a very difficult topic and our obstetrician colleagues are very much interested to listen to your ideas. The topic is maternal infections and its impact on neonates. Over to you ma'am.
Thank you, sir.
I request Dr. Aki sir and Dr. M. Patil sir to kindly chair the session.
Sir, is my screen visible, sir?
Yes, ma'am. Yes, ma'am.
Good morning, everyone. First of all, I thank the organizers of Neonatal Sepsis CME at BLDE Shri Patil Medical College Hospital and Research Center, Vijayapura, for giving me this opportunity. I must say, yet another opportunity to be a part of your academic activities at Department of Pediatrics. So today's topic is maternal infections and neonatal implications. As Sir said, this is a very difficult topic, and I have tried to make some justice to the topic. Hope it will be useful to us. So this is the focus of today's presentation. So this is a placenta. As we can see, the first placenta is a healthy one. The second one is an unhealthy placenta. So this is where it all starts, wherein the maternal infection is being transmitted to the fetus. So this is where it starts, and this will be the focus of today's presentation. So there are different routes of how an intrauterine infection is going to occur in a fetus. So these are the multiple routes. Out of them, the most common one that we know is the ascending infection from the vagina, and then it is going to go and infect the placenta and then to the fetus. The other one is if there is infection in maternal blood. So this is hematogenous spread from mother to fetus. The third one is whenever we are doing any iatrogenic procedure, that is amniocentesis, and then the infection gets transmitted to the fetus. But the most common one is the ascending infection from maternal vaginal tract. So these are the different routes of intrauterine infection. So how does this placenta get affected? So how does the placenta become unhealthy? So this is referred to as III. So as we all know, the term which was used all these days was chorioamnionitis, which has been now changed over to III. So what is this III? It is nothing but intrauterine infection and inflammation. So this is the new terminology which is coined by ACOG in 2016, and there are different definitions that are being put up to define III. So as we can see here, isolated maternal fever, there is a definition, and suspected intraamniotic infection, there is a definition. But overall, what we can understand is that the maternal fever is one symptom which is the most consistent in III, whereas the other, I can say, clinical features such as fetal tachycardia, maternal white blood cell count, purulent vaginal discharge, maternal tachycardia, uterine tenderness, these are additional criteria to diagnose III. So there are different definitions, and we can always read it later, but we need to understand there is a new terminology. And what was the purpose of this terminology? Let us try to understand. The whole point of coining this particular terminology was they were trying to correlate it with fetal outcomes as well as neonatal outcomes, and to some extent maternal outcomes as well. So we shall move forward with that. So we know that chorioamnionitis is an old term, but there is also something called as subclinical chorioamnionitis, because every mother may not present to us with maternal fever, maternal tachycardia, vaginal discharge which is purulent. We may not have uterine tenderness in all the cases. There are some mothers who do not have any kind of symptoms. There are some babies who are very much normal at birth, who appear normal at birth, but later go on to develop early onset sepsis. And we can always say that mother also had some infection. But it may so happen that mother and baby are asymptomatic to begin with. So this is another term which is called as subclinical chorioamnionitis. So here there are certain words that are coined, something like phenicitis and chorionic vasculitis. These are supposed to be histologic hallmarks of fetal inflammatory response syndrome. This fetal inflammatory response syndrome is fetal analog of SIRS, that is systemic inflammatory response syndrome, and it has also been demonstrated that amniotic fluid shows elevated levels of interleukin 6 in such cases. So subclinical chorioamnionitis is also something that we need to be worried about, because mother may not have any symptoms and newborn ends up with early onset sepsis and other complications of chorioamnionitis. So this is something that we all need to think about. This is something that we all need to try and diagnose, which is quite challenging. So this is the diagrammatic representation of fetal inflammatory response syndrome. As I said, phenicitis is one word and chorionic vasculitis is another word. So we can see here the infection, if it is confined to the placenta alone, or we can say the chorion and amniotic membranes alone, it remains as stage 1 and stage 2. But as it starts progressing towards the umbilical cord, that is phenicitis component of it, then we say that it is stage 3. So this is how it is going to occur, and fetus is going to mount its own inflammatory response syndrome, and it is fetal inflammatory response syndrome. So the most important thing that we need to remember here is it is not just the infection alone, it is also the inflammatory response, the inflammatory cascade to the infection that is also going to manifest, and that is the most common or most important reason for neonatal implications, both short term and long term. So should one use antibiotics before each delivery? This was one of the questions asked by my PG. Ma'am, if subclinical chorioamnionitis is so common, why not use antibiotics for every delivery? The answer is obviously no. But why is it no? Why, when we can prevent certain subclinical chorioamnionitis, when we don't have any way to diagnose subclinical chorioamnionitis, why not use antibiotics for each delivery? So this was his question. But using antibiotics also has its own problems, because it is shown that when we are using intrapartum antibiotics, the fetal gut responds in a different way. It was seen that it is all about the microbiota in the intestinal gut of the or intestine of the fetus, and it was shown that the intestinal microbiota or the gut flora showed reduced diversity. And it also showed reduced bacteroids and Acinetobacter and increased proteobacteria. So there was a lot of imbalance in the fetal gut, which was in fact having a lot of implications on the fetus as well as on the neonate. Hence, intrapartum antibiotics can never be the solution for solving subclinical chorioamnionitis. So there are other ways. Let us move on to those as well. So overall, this is the new thing that is coming up, the fetal microbiota, the neonatal microbiota. And before using each and every antibiotic, we need to consider this important aspect, because this is going to come up in a very big way, because this is something very much physiological and this is never going to go out of fashion, and we really need to pay respect to fetal microbiota. So coming to a term or a terminology that I would like to introduce here, that is dysbiosis. This is a beautiful article which is published in 2020. So what is the influence of prenatal and intrapartum antibiotics on intestinal microbiota colonization in infants? So if those interested PGs can go through this, and actually you can see for yourself what happens to fetal microbiota when we are using intrapartum or prenatal antibiotics. So it is not that easy to treat subclinical chorioamnionitis. So can I use antibiotics in PPRO? This was another question from my PG. Yes, we can use antibiotics when there is preterm premature rupture of membranes. So this was studied in Oracle 1 trial, but there are certain concerns here as well. So antibiotics are beneficial to improve maternal and neonatal outcomes, of course, but erythromycin and amoxiclav were compared in 4 different arms in this particular trial. So they help prolong pregnancy, they reduce surfactant and oxygen need, also reduce cerebral injury in the newborns. But there was one concern: when co-amoxiclav was used in mothers, it increased the rate of necrotizing enterocolitis in neonates. So this was one concern from Oracle 1 trial. PPROM is an indication for starting antibiotics. So which antibiotic to start? We need to have a unit policy. We need to have our own auditing of culture reports before we go ahead and choose an antibiotic. But co-amoxiclav, there was association with NEC, so let us be careful. So this was another question: can I use antibiotics in preterm labor without PPROM? The mother had just set in labor, but there is no leaking PV. So should I use antibiotics? Here the answer is no, and this answer is given by Oracle 2 trial. Antibiotics are not routinely prescribed for preterm labor with intact membranes and no evidence of infection. So each and every word in that sentence is important. So do not use antibiotics if it is preterm labor without evidence of infection. So antibiotics increase the risk of cerebral palsy when preterm labor was not associated with leaking PV or no evidence of infection. So this was one trial, Oracle 2 trial. This has its own implications. This trial was terminated early. There was only 70% follow-up. There are other concerns, but it has shown certain harmful effects of using antibiotics non-judiciously. Hence, let us be again careful in using antibiotics in such mothers. So this is another question: should I start antibiotics for all newborns if subclinical chorioamnionitis is so common? Because we end up seeing these newborns, or we end up seeing these newborns in a very sick state on day 2 or day 3 of life, and we were not able to pick up signs earlier. So is antibiotics the solution? Once again, no. We have other methods to tackle this particular problem. Better let us start taking high vaginal swabs. Let us send placentas for histopathology and look for evidence of infection rather than starting antibiotics. Let us start, I can say, practicing appropriate hand hygiene practices. Let us promote exclusive breastfeeding because we have no escape from these two measures. Regular and vigilant postnatal ward rounds, wherein even if we have any, I can say, the minimum suspicion of sepsis, let us send a septic screen and find out what is happening to the baby rather than blindly starting antibiotics. So antibiotics, even if we have to use, it should only be our last resort. It should be as per unit policy. How the unit policy is developed, it is not a blind policy wherein somebody puts up amikacin as first line, or I can say something like amox as first line, gentamicin as first line. That is a blind unit policy will not do. Let us take our own culture reports. Let us sit with them. Let us take high vaginal swab, and then let us also audit those cultures, and let us make a unit policy. This is something which even I have not done. Let me be very honest. So we are really trying to put in efforts here so that we bring in a unit policy about antibiotics, and antibiotics should not be started as per our whims and fancies. Let us respect the flora that are around us. Otherwise, we are disturbing the neonatal microbiota as well, as I have previously shown in one of the slides. So let us all try to find these solutions rather than starting antibiotics. I'm sure other pediatricians have a lot to contribute here. There may be other solutions before starting antibiotics. So anything that comes before antibiotics is welcome in this particular slide. So what are the short-term implications if a mother has any bacterial infection? It is not just bacterial infection. It was even found that viral infections as well as fungal infections also have their own effects or short-term effects on the newborn. So first one is preterm birth. This is quite self-explanatory. Birth asphyxia rates are increased because of maternal infection. Something called as complicated RDS, because simple RDS is something we give 1 dose of surfactant and baby does well. Complicated RDS is when a baby starts requiring 2nd dose of surfactant. This usually happens when mother has chorioamnionitis. So subclinical chorioamnionitis can also lead to complicated RDS. So this is where we need to think of subclinical chorioamnionitis, where baby is just not responding to 1 dose of surfactant. Neonatal sepsis and septic shock, because mother has infection, child also has infection. Congenital pneumonia, child goes on ventilator, and we see the X-ray, there are very heterogeneous patches, or it is not fitting into RDS, not fitting into MAS. So this is wherein we again think of subclinical chorioamnionitis and congenital pneumonia. Necrotizing enterocolitis is also a result of maternal infection. Of course, out of all the short-term implications, the most dreaded one is the mortality. So coming to the long-term consequences of the maternal infection on the neonate, brain. That is, there are three implications on brain: cerebral palsy, periventricular leukomalacia, and intraventricular hemorrhage. Intraventricular hemorrhage is a short-term implication, but it has long-term consequences. Hence, I have included it in this slide. Hearing deficits are seen in newborns. Anyways, we are going for like universal hearing screen. So we should be able to pick up these cases. Developmental disorders like autism and schizophrenia have also been implicated as a result of maternal infection. Retinopathy of prematurity, bronchopulmonary dysplasia, and acute kidney injury. These are also included as neonatal implications of maternal infection. So coming to effects on brain, there are three effects. Coming to the first one, it is the pathogenesis that is important here. Brain is not directly affected by infection. It is the inflammatory cascade that is affecting the brain. We all know that periventricular leukomalacia is because of pre-oligodendrocyte getting affected. Here, there is a direct toxic effect, or I can say direct inflammatory effect on oligodendroglia, which is causing the pathogenesis of cerebral palsy or PVL. Indirectly, it is by endothelial and macrophage activation, and there are multiple mechanisms by which these implications on the brain are happening. Cerebral palsy, it is again because of intrauterine infection or inflammation. So it is just not infection, it is just not meningitis that is causing cerebral palsy. It is also the inflammatory cascade that is causing cerebral palsy. And nowadays, with birth asphyxia rates are coming down because of HIE or because of birth asphyxia alone, or cerebral palsy not being a direct cause because of birth asphyxia. Nowadays, subclinical chorioamnionitis is going up on the list. So we need to be careful about this entity as well. There is a four-fold increased risk of cerebral palsy in the setting of chorioamnionitis. So this is again periventricular leukomalacia, the picture that is showing us that, and it is again because of the inflammatory cytokines. So there are again studies which have shown that white matter lesions are detected in such babies who were born to mothers with chorioamnionitis. Hearing deficits, it was found that at 18 months of age, there was speech delay and hearing loss when in babies who were born to mothers with chorioamnionitis. Once again, autism and schizophrenia are also attributed to inflammation in the fetus. So this FIRS that I quoted, that is fetal inflammatory response syndrome, is the pathogenesis behind most of these morbidities. Coming to retinopathy of prematurity, we know that every baby with sepsis, irrespective of birth weight and gestation, should undergo ROP screening. Even if it is suspected sepsis, even if culture is not showing us anything, even if septic screen is just borderline, we are not diagnosed sepsis in this baby, still we need to subject these babies for ROP screening. So acute kidney injury, this was shown that in some of the animal models, it was shown that when mother has chorioamnionitis, fetus has a lesser nephron endowment. It is the reduction in nephrons is by 20%. So this can have long-term implications causing chronic kidney injury. Then coming to some of the studies which have again substantiated these findings, we can see here there is CLD, ROP, IVH of all grades, and there is PVL. So this is another study which is again showing us that the cases had higher rates of CP, IVH, and ROP as compared to controls. This is yet another study which is again showing the same results with a significant difference between cases and controls with respect to cerebral palsy. This is again another study. So there are a lot of studies that I can go on talking about, but there is time limit. Hence, I would now like to move on to one important infection in the mother, which can have implications on the newborn, that is maternal HIV. As we all know, the rates of vertical transmission of HIV have reduced to less than 5% thanks to effective PPTCT services around us. There is triple drug regimen which is given to the mother. We have strengthened PPTCC services. We have informed feeding decisions. That is, it was believed that a mother who breastfeeds her baby is going to transmit the infection to her baby. But with effective triple drug regimen, the rates have come down. The transmission rates have come down. And it is recommended that in developing countries, if the mother is not satisfying the FAST criteria, we can still go ahead with exclusive breastfeeding, giving the mother triple drug regimen for life, and giving nevirapine prophylaxis to the baby. I'm sorry, it should be nevirapine prophylaxis in the baby. Early infant diagnosis, that is, we also test the baby for HIV at 6 weeks of age. Co-trimoxazole prophylaxis is started at 6 weeks of age. Continued infant follow up to 18 months of age has been advised. So it is not complete without talking about COVID-19. So we know that when a mother suffers from COVID-19, we also have neonatal implications. Early onset neonatal COVID is one manifestation, late onset neonatal COVID, and we also know that multi-system inflammatory syndrome has also been described in neonates when the mother suffers from COVID. So this is the pathogenesis. I can always share the slide if any PGs are interested. So these are some of the infections, or the most common or the most relevant infections from the mother to the baby that I thought I should be putting up. So this is the summary. It is the inflammatory cascade which is more deleterious than the infection itself. So chorioamnionitis or triple I, that is intrauterine infection and inflammation, when detected early and effectively treated, can help improve the maternal and neonatal outcomes. So take-home messages are that placental histopathology or culture and high vaginal swabs, we need to know our flora, we need to regularly do it on mothers, and we need to have our own auditing of these reports so that we come up with the rational antibiotic choices. Hand hygiene and exclusive breastfeeding, whether it is early onset or late onset sepsis, we do not have any escape from these two. And I know sir is going to talk in detail about hand hygiene. And then coming to the antibiotic stewardship, this again depends on the first point. We need to know our flora so that we have effective antibiotic policies. Multi-drug or pan-drug resistant organisms are going to be a reality. So we are going to face culture reports wherein the organism is resistant to all the antibiotics. So this is going to happen very soon. So what are we left with? We are again left with hand hygiene. We are again left with exclusive breastfeeding. We do not have any other escape route. We may have to find out antibiotics which are stronger than what we already have. The highest possible that we can think of, the colistin, tigecycline, we may have exhausted all our options. And we may be having organisms which are just pan resistant. So we have to allow the mother to make antibodies to such infections. So promotion of exclusive breastfeeding is our way forward. So with that message, I would like to end my talk. From error to error, one discovers the entire truth. So we are still making a lot of errors in this particular area, be it antibiotic choice, be it placental examination. So there are multiple problems we need to address. So let us try and get nearer to the entire truth as much as possible. We all know that we are still far away from it. I once again thank the organizers for giving me this opportunity. Thank you, sir. With that, I conclude.
Thank you, madam. Thank you, madam. It was a very nice presentation.
Thank you, sir.
And you have brought out the new concepts of triple I and subclinical chorioamnionitis. And I have mentioned one interesting study of erythromycin versus coamoxiclaw supplementation during pregnancy and effects on the fetus. I want to know, madam, you said increased risk of PDC in the baby. So is it due to amoxicillin or clavulanic acid? Because many times in amoxicillin, it is because of clavulanic acid that will be responsible for many of the adverse effects. For example, if you add amoxiclavulanic acid in a patient, they may develop folic acid because of clavulanic acid, not due to amoxicillin itself. Is that the study have mentioned anything about either this amoxicillin or clavulanic acid?
Sir, this study, like I just quoted it from Oracle study. So it was coamoxiclav which was used in that particular trial. So I'm not really sure by which component of it was causing the effects. To be.
I am asking this question in many times our obstetrician starts subtriaxial sulbactam. This is the word. Other things, sulbactam and clavulanic acid is responsible for the majority of it rather than parental itself.
The point well taken, sir. But probably I do not have an answer. If anybody if you would like to explain further, fine, sir.
Madam, our center is a part of this A plus study. A plus means azithromycin prevention of infection in labor use study. Currently, the study is going on. In the next 1 year, we will have results. We'll wait, madam. We are routinely supplementing azithromycin to the woman who is in labor and seeing the effect of azithromycin prevention infection both in the mother as well as in the baby up to 42 days.
Okay, sir.
Madam, I have 2 questions.
Ma'am, what is the role of antibiotics in neonates born to COVID positive mothers?
I did not get the question, sir.
Ma'am, what is the role of antibiotics in neonates born to COVID positive mothers?
Okay. Okay, role of antibiotics in newborn who is born to COVID positive mother, right? Okay. First of all, this is from Naveen Jain sir's talk that I'm quoting, that we need to stick to basics. Whether the child is born to COVID positive mother or COVID negative mother, we still go on with our routine examination. If baby is asymptomatic, we are not starting this baby on any kind of antibiotics. We promote exclusive breastfeeding so that baby is going to receive those antibodies from the mother. So only if baby is going to manifest any signs, or if the baby becomes symptomatic at any point of time, we are again going to evaluate this baby just like any other child. We are going to do RT-PCR in this child at 48 to 72 hours of age. We are going to see the report, and then only, like, it is just not the report, it is also the baby's symptoms that we are going to give respect to. And again, the antibiotic policy of the unit is going to matter. So there is no uniform role of antibiotics in babies who are born to COVID positive mothers.
Another question: if the mother has fever, cough, and cold 2 days prior to the delivery, should we?
Sorry, could you be louder? I am not able to.
If the mother has fever, cough, and cold 2 days prior to the delivery, should we prophylactically start antibiotics in the baby?
I'm sorry, sir, I couldn't.
I will repeat it. Role of prophylactic antibiotic in neonates born to mother with flu-like symptoms 2 to 3 days prior to delivery or a week prior to delivery. Nowadays, I think you have also come across mothers are coming up with RS presentations. They are quite common. Yesterday night,
Yes,
we have around 2 to 3 deliveries, and moreover, they are being late preterm, 35, 36 weekers. So they were asking me, sir, should we start broad spectrum prophylactic antibiotics? I said, madam will answer the question for us.
So the only thing is that, like, what I would like to say is, actually, I have not put up that study here. There was a survey which was done among Indian mothers, and all the obstetricians were asked how many of them are administering antibiotics to these mothers, at least one single dose of antibiotic just prior to labor, let alone mothers with fever. There were mothers without fever, and 70 to 90% of the mothers without fever were also administered an antibiotic. So this was the survey. So when a mother has fever, definitely there is no hesitation to start antibiotics. There is no hesitation. This is the practical problem that we have. Even without fever, they are administered antibiotics. When there is fever, so coming to the question, when there is fever 2 to 3 days prior to delivery, let us administer antibiotics, because these mothers warrant the administration of antibiotics. But still, if we are sure that it is viral infection, then maybe, like, it is up to the obstetrician to take a call. Probably, I'm nobody to give an uniform recommendation.
Antibiotics. Does this babies need antibiotics basically?
Yes, sir. So there are, yes, sir. So there are problems. Sorry, sir. Sorry to interrupt you. There are problems if the mother has fever and baby is going to get that infection. We always have that scare. But administering antibiotics is also not safe. Dysbiosis is a problem again. So we need to take a benefit risk ratio and then only administer antibiotics. We need to make sure it is a bacterial infection before giving antibiotics. Let us try find out the focus of infection. Let us try to diagnose the mother before giving her antibiotics. It is very like, it is better said than done, but let us at least give a trial.
Sir, you want to add something on that? Praveen sir, hope I am audible to you.
Sorry, sir.
Praveen sir, am I audible? Yeah.
Yeah, the message when I missed that. Sorry.
Yeah, would you like to add something on that?
Ade, can you repeat that girl's question? The antibiotics for the fever or without fever?
Mother with fever 2 to 3 days or 1 week prior to delivery, and role of antibiotics in neonates.
Oh no, definitely not. Like, we use the NNF criteria for risk stratification, and based on that, whether to start antibiotics, whether to do the septic screen, that's what we follow.
Yeah, we have one more question, ma'am.
Ma'am, I just wanted to know, like, are there any diagnostic criteria for FIRS?
So diagnostic criteria for FIRS, sir, if I heard the question right. Yes, sir. So there are predefined criteria for FIRS, but there is no uniform recommendation as such. But it is all part of diagnosing triple I itself. And FIRS is one indicator. There were a lot of inflammatory cytokines that have been studied, but the most consistent association has been with elevated levels of interleukin-6 in amniotic fluids. So that is one association which has been found. Otherwise, there are no criteria as such to diagnose FIRS alone. It is most of the times it is a retrospective diagnosis to the best of my knowledge.
Thank you.
Thank you, sir.
Morning, ma'am. I congratulate you for an excellent talk on the entire coverage of services. My question is, what is your audit, culture audit of your NHP? What are the pros and what is the normal benefits you use for?
Yes, sir. So auditing.
You commented in your presentation that the audit of the program region that would be more thinking and developing stewardship. What's your audit as per say, and I think I would like to share everybody's, because what we are coming across, whatever questions I had, I could get your answers through your summary. Most of the questions have been answered already. The use of these ticketcycline, colistin, and fungal and other things. So I just wanted to know what is the growth in your NS at your place.
Yes, sir. So we did try to audit our culture reports. So far we have been able to only know the type of flora or type of organisms that are around us. We have not been able to make a uniform recommendation on antibiotics as such because the organisms keep varying. This being the referral unit, the outborn unit, sometimes before the baby is referred, baby is already on meropenem and vancomycin. So we are not able to make a uniform recommendation on antibiotics, but all I can say is the most common organism that we are isolating here is Klebsiella, followed by Pseudomonas and Acinetobacter, closely followed by Pseudomonas and Acinetobacter. We had one unit which was referring cases to us, and we found that they had E. coli as one of the most common organisms. So consistently that unit was growing E. coli. We did alert the obstetrician and they took measures so that subsequently the E. coli rates came down from that unit. So this is the maximum we have been able to do so far. But coming to the antibiotic choice, sir, we are still not able to make a definite pattern as to this is the antibiotic that these organisms are most commonly sensitive to or most commonly resistant to, because it varies a lot. And we still try to stick to some of the broad spectrum antibiotics only because babies have already received 1 or 2 antibiotics before coming to us most of the time, because our inborn rates are very few. And most of the times we have babies who have already received antibiotics outside.
Thank you, ma'am. I will take that. I end of your statement. The same thing with our IC also. And maybe we'll have to redefine ourselves with the newer things and newer policies. But still, again, as you said, the advocacy of hand wash is the mainstay. It's going to be the right message, right way. Thank you, ma'am.
Thank you, sir. Thank you, sir.
Thank you, sir. I thank Dr. Patil sir and Patil sir for chairing the session. We will move on to the next session. Our staff performer, Dr. Praveen Venkatagiri sir. Sir doesn't need any introduction. He is well known to all of us. Sir is leading right now on group of hospitals. Sir would like to talk in Canada with us today regarding hand hygiene practices. What do you say?
Yeah, thank you. Good to see everyone, and also.
Sir, one second.
Can you hear me?
Yeah, one second. I request Dr. Rakesh Brankar sir and Kailash Shetty sir to say this.
Maybe I'll. Can you hear me now, Shri?
Yeah, yes.
Good morning, sir.
Hi, good morning, Chennai. Sure. So, can you confirm that you can hear me?
Yes, sir.
Yeah. Thank you. Good to see everyone, and especially the students that we interacted with just a couple of months back. I saw them in the audience, so nice to see them. So today, Sidhu wanted me to talk about hand hygiene. So before that, okay, so yeah, I can see the students now. So let me ask you a question then. Either any nurse or PG, can you show us the steps of hand wash, please? Come on, somebody can do that.
Thank you, sir, for making it interactive. Let us start.
ತೋರ್ಸಿಮಾ ಯಾ ನೀವು ಕಾಣಿಸ್ತಾ ಇದ್ರ
ರಿಕ್ವೆಸ್ಟ್ ಮಾಡಿ ನಮ್ಮವ್ರು ಮಾಡಿದ್ದೀನಿ ಕ್ಯಾಮ್ರಾ ಫೋಕಸ್ ಓವರ್ ಟು ಯು ಸರ್ ಟು ಆಫ್ ದೆಮ್ ಕ್ಯಾಮ್ರಾ ನೋಡ್ರಿ
ಅಲ್ಲ ಅಲ್ಲ ನಾಟ್ ಫಾರ್ ಮೀ ಎವ್ರಿವನ್ ಹಾಗೆ ತೋರ್ಸಿಮಾ ಪರವಾಗಿಲ್ಲ ತೋರ್ಸಿ No, I can see it fine. Yeah. How did she do? Yeah. How did she do? In my ಎಲ್ಲ steps ನೆನಪಿತ್ತಾ?
ಮೈಕ್ ಕೊಟ್ಟಿರಲಿಲ್ಲ
Okay. Now, ಆಯ್ತು ma'am. Can the PG student show what are the steps of hand rub? రెడ్డి గారు చూపేయండి.
Then mainly we should cover the rib spaces between the fingers and over the palm aspect.
So did you do all the steps? Are you sure?
First step, second, third, fourth, fifth, sixth.
No, did you do all the steps when asked? Any reason you cut short some steps? Any reason you cut short some steps?
No, sir.
Okay, sorry, I mean, my network is a little bit problem. So we've seen the steps, and also we were asking about, like, why some steps are always kind of a miss. I want to ask now the in charge, Dr. Sidhu, when people know as well what happens, what is the complaints rate for the hand wash and hand hygiene, hand rub? Okay, sure. So that's the point I just wanted to make before I'll start sharing my screen now. Sidhu, you can see my screen?
Yes, sir.
Yeah. So this lecture will be completed in 3 slides. First slide is how to do hand hygiene, that is a hand wash. Next is what are the 5 movements of hand hygiene, which is before touching the patient, before clean or aseptic procedures, after body fluid exposure and risk, after touching the patient, after touching the patient surrounding, and then hand rub, how to do it, for how long to do it, and what is the procedure. And that's the end of hand kind of a hygiene. But that doesn't end there, because this importance of the hand hygiene has been known for centuries. So in 1800s itself, one gentleman, Semmelweis, has established that hospital-acquired infections were transmitted via hands of healthcare professionals. Now, what he observed as a house officer, mind you, he was a house officer, that maternal mortality rates were with puerperal fever was higher in one clinic compared to the other, significantly higher. Now, he also noted that doctors and medical students often went directly to the delivery suite to deliver after performing autopsies and had a disagreeable odor on their hands despite hand washing with soap and water. It's a simple observation, and that he hypothesized that these are the cadaveric particles which transmitted via the hands of the doctors and students, and that led to the puerperal fever and hence the higher mortality. So he recommended using scrubbing with chlorinated lime solution, following which the mortality fell down drastically to 3% in the clinic, and that remained low thereafter. So this was a couple of centuries back. So where are we now? We just heard 150% in one place. It could vary from place to place, but still almost everyone knows why hand hygiene is required. Almost everyone knows when this is required, and almost everyone knows that this is not happening as per the recommendation. So how do we tackle that? There's a WHO guide to implementation of hand hygiene that I strongly recommend everyone to go through that. This is mainly for the patient safety, and hand hygiene is one part of that. So what are the steps? First step is you have to build it. That is a system. What is a system? The system involves the infrastructure. So you need to have adequate resources for the hand hygiene, the equipment, supplies, and also human resources. If we have inadequate staff and and higher level of care being provided, we cannot expect the hand hygiene to be very high. And what are the physical environmental influences that health workers have? How ergonomically the place is designed, and what are the human factors that were taken into consideration while designing the unit. So these are the things that in the decision during the design itself must be taken. Second step is once you build a place, you teach or train and educate people about the hand hygiene. Basic knowledge is important. And what are the type of training material should be used, how it has to be delivered, everything must be planned. Does the facility have trainers, training aids, and all the necessary equipment that that is the responsibility of the senior people. Programs and models of hand hygiene promotion, including patient and healthcare worker empowerment. You need to have regular education programs regarding that, and also reminders and motivational messages. Each unit can have their own way of motivating and sending reminders. These are visual reminders, not just at the point of hand wash, maybe in the other areas as well. Usually include small badges or stickers worn by patients or healthcare workers, like, did you wash the hands? Ask me if I have washed the hands. So you can create your own messages so that it forms a reminder and the compliance should improve. Role modeling is extremely important, as studied by McGurkin and his colleagues, that when the authority figures act as role models, the compliance is very good. For example, medical directors, nurse managers, or director of nursing and infection control professionals can record short audio messages or video messages talking about the complaints and following those rules, that demonstration of that. And this should be broadcasted randomly at timed intervals so that everyone is aware of this most important aspect of prevention of infection. Third one is, okay, you have a facility, you have educated, but how do you know how much is the complaints? What is the feedback? So you need to identify the gaps in infection prevention protocols and have indicators in the settings to allow what to prioritize and where to intervene. And how can you be sure that the intervention is being implemented correctly and safely, and you are in the right direction? So monitoring hand hygiene by direct methods requires asking these questions like, are we making the progress towards the goal of increased hand hygiene compliance? How will we know when we have reached our goal? Goal typically is to bring the compliance above 95% by introducing the system improvements, behavioral incentives, education, and other interventions. In order to judge the effects of the interventions, first we need to know what is our baseline measures that should be taken on in our units, and improvement should be commenced. The performance over a time can be compared with the baseline and decide a target or goal. So the two key concepts that decisions need to be made is, what is the number of data points needed to represent accurately the variation in the process, and the number of observations need to be included in each data point. The baseline data point generally obtain around 30 data points before analyzing the variation in the process, because it's generally observed that stable distribution of the results starts to form when you have around 15 to 25 data points. And to track the progress, you need to measure a percentage of number of times healthcare professionals were observed to have appropriately washed his or her hands before and after a patient encounter. That's the numerator. And the denominator is the total number of observations made. General guide for that is that you make about 12 to 15 observations in the denominator before the percentage is calculated. So what you do is select a unit, whether it's an NICU, ER, PICU, wherever you wanted to pilot. Select a random day of each week to observe the hand hygiene compliance. On selected days, collect a minimum of 15 observations of hand hygiene opportunities, that's the denominator. Out of these opportunities, determine around 20 times hand hygiene, whether they're completed or not. Compute the percentage of hand hygiene compliance for that week, and you need to repeat the process for 4 to 5 months as the work goes forward on improving the compliance. And use a run chart to assess the direction of improvement, whether you are in the right direction or not. Once you are seeing improvement, you start selling it. That is, you have to gather more support from one unit to extended units and whole hospital like that. How are you promoting an intervention which is working to other areas? And also, do you have capacity or funding to develop promotional messages and materials? These are all need to be planned. And beyond that, not just as a project, if you make it like a culture, like everyone, every day, every time thinks about the hand hygiene as an important measure to improve the patient safety, it has to become a culture in the organization. And it's a huge challenge. It's not at all easy in any place. Is there a demonstrable support for the intervention at every level of the healthcare system? Do senior managers provide funding for that? Are teams involved in co-developing or adapting the intervention? So how well you are able to convince other teams to get involved is also extremely important. And this is the place where leadership plays a very crucial role. So how do you sustain the changes? You create e-learning tools so that you can check the progress of the people, of individual nurses or doctors. They complete the module, they should report to you, and then you could do testing as well. Once you create these e-learning tools, or some of them are available in the internet, you can repeatedly do that every 6 months or so, depending on your attrition rate as well. And symposia and lectures, like how you are excellently conducting a program on prevention of the sepsis, repeatedly that has to be done for all the areas. Posters and publications, so posters in the hospital as well as publications to share the scientific knowledge and also how you are able to achieve certain things and motivate the people will be important. And involving the patient and empowering them will definitely help in many settings, but may not be applicable in all the settings. That is something for each unit to consider and take a decision on. Sharing experiences. So regularly in your audit meetings, you can discuss that. Typically, like NABH or accreditation process, if you are going for, you will have to be measuring them and present at each area what is the compliance rate. Personal accountability and rewards for the compliance cannot be ignored. You can give awards for, like, champion of the month, like that, so that you are creating that culture of patient safety. So this is the, again, from the WHO, everything that I have presented today, from multimodal component of system change, which is, where are the alcohol hand rubs available at the point of care, whether continuous water supply is available, soap and towels are available. It might look simple here, but it is not easy to ensure all of these availability at every point of time. Training, education, evaluation and feedback, reminders in the workplace, and institutional safety climate. So the summary is there are 5 steps that we mentioned: system change, training, evaluation, reminders, institutional safety climate, emphasis on 5 moments of hand hygiene, and stepwise approach towards facility preparedness, baseline evaluation, implementation, follow-up evaluation, and review and planning is required. I had my own challenges in every place that I work in terms of hand hygiene. We all know that the senior the person is, the poorer the hand hygiene practices are. That's been clearly documented in most of the places. So whenever we get an infection outbreak, we tend to get very emotional and we start several kind of a plan. So one of that was we tried something like, okay, we've seen an infection, so I want everyone to send the photographs of, every shift. Immediately after the shift, wash the hands and send a photograph in the WhatsApp group. So it's just like, trying to get the focus onto the hand wash. And you can guess what happened, right? I mean, in the beginning, we tried even the video of hand wash. We thought of placing a CCTV there. All this won't be lasting for a long time. It just now and then brings in the focus onto the importance of the hand hygiene, and also showing that senior people are aware of this, and leaders want everyone to really be committed. So our commitment will be reflected by how we behave when we come inside, and also how we support everyone to perform hand hygiene at every point. The compliance currently in one of the hospitals is around 85 to 90. It varies between that, but these are all snapshots at every week at one particular point of time. I also tried in the remote areas outside Bangalore, around 100 kilometers away, where the hand hygiene concept itself was not there. Through camera and apps like that, as you could see, once you train them, you can always do the procedure monitoring as well. This is practical only if you have a smaller number of beds or smaller number of people to monitor. Large number becomes difficult. In the similar place, even monitoring of the procedures, and you train them first of ANTT, and then you see whether the compliance to that procedure is happening or not. Again, a snapshot, and also a reminder to the on-ground staff that somebody is monitoring. There are more technology kind of solutions that I'm working on, but again, these are all not proven yet. But that is something I just quickly wanted to share like this. I don't know whether you are able to hear the audio. It's a feedback mechanism where the app guides the clinician or the nurses of the steps, and it records if a person is doing all the steps or not, and each shift that data can be given to the leadership, so that it's again a tool just to improve the hand hygiene. So so there is a voice there coming which will guide them. So you will have to figure out what works for you in your unit, and that you'll have to see whether you can implement. And thank you.
Very nice talk, Dr. Praveen sir. You nicely talked about all the concepts of hand hygiene and its importance. Just wanted to know, like, how you are preventing the use of mobile phones when the personnel working in NICU. Well, that's also one of the important contributors to infection and disease.
Actually, I could not hear the question very well.
Use of mobile. How you are able to prevent the use of mobile phones?
Prevention of mobile phone infections.
Yeah.
No, actually, that unit policy to unit policy, I work in different units. Not in all units, the mobile phones are banned. So the way that is, like, there's a kind of a, when they are entering, they place in a, box, and then they don't take it inside in the units where the mobile phones are banned. At the end of the day, mobile phones definitely are a risk, but more risk is, even if they touch the mobile phone, are they, doing the hand hygiene procedure or not? That matters more. We can, that emphasis is what we should be focusing on, I think.
Any other questions?
How do you motivate your staff based on for hand hygiene?
Yeah, no, it's a huge challenge, right? And again, it varies from place to place. See, it's easy for me to either shout at them or motivate them, because I'm not there 24/7 inside the NICU, right? The challenge is the people who are there inside the NICU, they have to work with them as well. So that relationship with the nursing staff and junior medical staff is important. The way we kind of done is, sometimes the certificates are given if there is no kind of a infection outbreak in the unit. And the other things, like in another hospital, they will be displaying the name of the nurse, like a champion, like that. So individuals you can motivate like that. Whole team motivation is through presentation of the data only. If you have a run chart stuck there and showing the hand hygiene improvement, that motivates most people. By looking at it, that compliance is getting better.
The ideal composition of an hand sanitizer, percentage of alcohol.
Sorry, you're not audible.
What should be the composition of an hand sanitizer, like percentage of alcohol?
I think you're asking about the composition, right? Of the
Percentage of alcohol.
Yeah. Correct. So like, which one are you using currently?
Isopropyl alcohol. Chlorhexidine and isopropyl.
Chlorhexidine, I heard, right? See, alcohol-based hand rubs are the recommended, and soap and water if you are using it, the hand wash like that, right? So of course, if you are, I didn't know if you're asking for the cleaning material and stuff, that's they are different, but the hand has to be the alcohol-based hand rubs.
The question concept behind was that at times the periphery resources limited settings, we tend to use 100% spirit. when the chlorhexidine or a proper sterilium is not available. Sterilium itself will cost around 150 200. Sir. And we keep on prescribing them, that will be difficult in resource limited settings like us. And you can say that we tend to use a 100% spirit or something of like that sort with dilution. So Madam wanted to know, she's a neonatal fellow, sir, Dr. Gautami. She has completed her MD pediatrics. She is doing NM fellowship with us right now. She wanted to know, is there any ideal composition or anything you do in your peripheral settings?
No, really. Actually, I know that the dilution is being used. The composition, I'm not very sure. I can check and let you know, because the WHO document has that details. They have clearly given what composition up to what kind of this thing is available.
Yeah, you don't recommend 100% spirit, right?
No, no. Hands will burn.
That's the message. Excellent.
One more question. The use of head caps in NICU, should it be worn regularly or in the procedures?
See, the voice from the audience is not reaching.
Sorry, sir. Nothing. Sir, usage of skull cap or head cap in NICU 24/7 or during procedures. What do you recommend, sir?
Yeah, see, that's what we get stuck on to the things which we see somewhere and then we think it works. Don't get stuck on to these things. If you think that it's working, please go ahead and implement that. There's nobody who will will be telling you that this is exactly what you should be doing. Yeah, because in many places, like in the West, we used to come with the shoes that we walk on the road inside the NICU. We don't even remove the shoes, right? That doesn't mean that that is the right practice here for us, correct? So practice is what is applicable in our own units will have to implement. Now, using the kind of a head cover definitely is required for the procedures and stuff. But all the time, are you going to recommend? It depends. If your staff is not compliant and they're touching their hair, they're touching their nose and stuff, and you are not there to monitor, you're trying to implement that. So you'll have to go by what kind of a knowledge base and what kind of a people you have around. There is no definite hard and fast rules for that. I hope that answers your question.
What do you do in your unit? In your unit, sir. Am I audible, sir?
You're asking me?
In your unit.
We don't use any routine headscarves in all the places. It's a half and half. But in one missionary hospital, it's been used. In other places, it is not used.
Prashant, you would like to take on that? What do you do in your unit? Prashant?
Oh, hi. No. So no, we don't use skull caps, and I don't think there is any evidence to routinely use skull caps in the NICU.
Okay. So the message is clear that there is no evidence to use skull caps in NICU routinely other than procedures. Both of you recommend that? Sir, you're not audible, Praveen.
No, the point again, Sidhu, is that how can I recommend something for the unit that I am not working in, right? So we'll have to be. No, I don't want it. But at the same time, if your nursing staff is touching the hair every time, that's what you're noticing, and you think this is going to prevent, see if it's going to prevent. If it really is going to prevent, you use that. If it is not preventing, don't just put in additional barriers.
Okay, sir. Thank you, sir. Sir, any questions? Rakesh, sir. Dr. Rakesh, sir, our colleague, assistant professor, Department of Pediatrics.
Thank you, sir.
Hi.
Overview talk on hand wash and hygiene. And I thank you for giving such a nice talk.
I'm sorry, again.
So thank you for the wonderful talk, sir. It was very informative and good for the hand hygiene and thank you, sir.
I'm sorry, I lost you there in between. Sidhu, what was the question?
No, sir. It was, sir was telling thank you and it was informative, sir.
Oh, yeah.
And
Thank you.
work on your internet, sir. Sir, we'll move to Prashant's talk now. Right? Yeah. I would like to ask Dr. Anil Sachin sir and Ramakrishna sir to kindly chair this session. I'm correcting myself this time. I'm calling the chairpersons first. Now I request Dr. Prashant YN sir, a neonatal intensivist, Bangalore. Sir is going to join practice shortly. Sir has done his DM neurology from St. John's and one of the workshop pioneers in managing an outbreak in NSU. We love to listen to you, sir. Over to you, Dr. Prashant.
Hi, very good morning. I thank Dr. Sidhu for providing me an opportunity to be with you all. I'm going to talk about managing an outbreak in NICU context. And I'll be sharing a few of our experiences from our own unit here. I hope my slides are seen and I'm audible.
Yes, sir. Yes, sir.
Sure. So in 2003, when a SARS pandemic ravaged the world, we had struggled to get to know the mysterious source and the mode of transmission to actually tame it. So here is a schematic diagram of how a source was tracked down to a person in Hong Kong, and many hypotheses and many evidences just to know how this SARS virus, transmitted between people and led to clusters. There was outbreak, turned to epidemics, and then finally pandemic. I mean, this COVID outbreak, I think everybody in India probably know a bit of managing this epidemic and pandemic. And we all know that the most important thing is detecting and investigating the source, forming a scientific basis. That is, we need to have scientific studies into it, and we need to involve the administration. We need to contain it, both the virus as well as the spreaders. And the most important thing is to communicate. So this looks pretty simple, but it has a lot of efforts in the background. So what do you mean by epidemic and what do you mean by pandemic? So an epidemic is an outbreak, but it is a more widespread or it is prolonged. But an outbreak is an occurrence of more cases of a disease than expected in a given place. And it will be among a specific population, and it will be amongst in a particular period of time. So an outbreak which can lead to epidemic, and an epidemic can lead to pandemic. So this is how the hierarchy is. And outbreak in an ICU context. So we can have blood culture positive outbreaks, where an outbreak include 2 or more isolates of the same species with the same antibiogram within a span of probably 2 weeks. And we can also have a surveillance culture positive outbreak, where 3 or more infants screened positive for the same gram-negative bacilli, or a rare gram-negative bacillus, that is ESBL or MRSA, can trigger an alert. So this is in context of an ICU outbreak. So when you have an outbreak in your ICU, so we always ponder, should I start investigating, or should I involve an epidemiologist? Probably because it's an investigation and I'm a doctor, I can't investigate. Or because I'm a doctor, let's just treat the patient rather than waste time on investigation. Unfortunately, we all know from our MBBS days and being doctors, we need to be managers of our ICUs, we need to be doctors, we need to take care of everything in our ICU. And we probably need to balance these 3 aspects. So why do we need to investigate an outbreak? Because we definitely need to address we need to prevent the additional causes of an outbreak. We need to check the further outbreaks. We need to assess our strength of infection control practices, whether it is going fine or not, or probably if you don't have any infection control practices, which is practiced routinely in our NICU, it's an opportunity to put in place if it doesn't exist. We can learn about new disease and a new thing about an old disease while during we manage this outbreaks, and it ultimately it decreases the economic and social burden, and it also improves the NICU outcomes. It decreases the burden of the nurses and healthcare professionals, and it also helps us to teach. So when we have an outbreak, we usually have a causative organism which could be known or which can't be known, and we also have a source of transmission, right? So we need to have this. Most of the situations our causative organisms are known. and probably if you know this causative organism, the mode of transmission is also known. So there, the highest priority is to control, and probably we also simultaneously have to look at investigation, but it could be of low priority. And this could change. So the priorities of whether I have to investigate a outbreak or whether I have to control an outbreak varies with these aspects, whether the causative organism known or if it's unknown, and whether the mode of transmission is known or unknown. So most of the times, the causative organisms we eventually will get to know with the newer modalities of blood culture, where we actually get the results very soon. Once we know the organism, we know how the transmission happens. So here is a story of our own unit. So I am talking about a high dependency unit where we had 12 beds. So where there was an outborn who was admitted. It probably can reflect your story also. An outborn with the mass pneumothorax, which expired the day the baby got admitted. So in the next couple of days, a baby who was HIE2, who was actually getting cooled, expired because of collapse. And we have in the subsequent couple of days, we had a very preterm with RDS. This baby also had collapse, and this baby expired. And there was an other baby who got admitted on the same bed of where the first baby was there, and that baby eventually died because of collapse again. But in between all that, we also had one baby who got admitted with CDH. But that, I mean, so when we are struggling to stop this kind of deaths, and before we knew what was happening, we got to know that these babies blood culture were actually growing MDR Acinetobacter. So this CDH baby got benefits, benefited with that. We had to upgrade the antibiotic to colistin, and that baby eventually survived. So, and finally we realized the source was this, which got admitted on this bed, which was an outborn baby which died. Which died. Retrospectively, we went back and checked the baby's admission culture, which turned out to be positive for Acinetobacter MDR. And I'm sure this will resonate with some of your own stories in your unit, isn't it? So let's see. And the good part is, since we got to know the organism and probably how it was spreading and upgrading of antibiotics at appropriate time, this CDH we actually could save. So this underlines an important aspect of investigating an outbreak, and also steps to contain this outbreaks, because ultimately we're going to lose babies because of infection. CDC gives steps to investigate an outbreak, but this is all for epidemiological outbreaks, like we just saw this SARS-CoV and other thing which actually spreads in the environment. And Indian guidelines also gives 10 steps to contain outbreak, but this also will be for this also is for epidemiological or field works. So we need to kind of have our own steps which are pertinent to our NICU. So this is this steps of outbreak management which I'm going to talk about is modified from CDC Indian guidelines, as well as the ones which we had made in our own unit. To start with, we need to recognize an outbreak, which is an immediate priority. That step one is to verify the diagnosis and establish the existence of this outbreak. And the next step would be to report an outbreak and search for information about the outbreak or the organism. Step 3 will be to study the event and start the first control measures. And step 4 obviously is to implement the control and preventive measures. And the other most important thing is to communicate the findings, probably within the administration as well as others. So these steps need not be one after the other. It could be simultaneous, or it can be of any order, but ultimately all the steps needs to be done before we call it as an end-to-end outbreak management. So to start with, how do we recognize an outbreak immediately? So it could be an alert from an effective surveillance system. So as you can see in this run chart, which we have it over years. So if you find there is a sudden spike in your in your infection rate, that should alarm. And an alert could be from a physician, an alert could be from a nurse or a microbiologist. And a resident doctor might say that, we are probably seeing the same infection. So that baby had one infection, and this baby also seems to have the similar kind of infection. Or news we might get that, two of the blood culture actually are actually growing the same organism or something like that. We need to be open to get these alerts from various sources. And there could be similar cases in the unit. There could be similar cases among similar patients, similar cases in a short time period interval, and healthcare workers and patients can also have the same similar infection. So these are the clues which will tell us that, okay, the possibility of an outbreak is imminent. So with this, we need to verify the diagnosis and we need to establish the existence of an outbreak. So what do? We need to look at our past unit data, preferably in that season, with the infection rate of the presumed outbreak. If you see that there are over a period of time, the infection rates are pretty constant, and to see that probably it has spiked a lot within a short period of time. So in, for example, like I mentioned in blood culture, positive outbreaks. So it is 2 weeks. So within a short period of time, we need to probably get into the mode of outbreak management. We need to define the case. We need to involve the person, place, and time. These three are important. We need to define a case as any NICU baby which is growing a particular organism from any site. We can also call them as probable cases if any baby with culture negative but screen positive and probably X-ray features or some other features which are similar to the definite case occur. We can also call them as clinical cases if the clinical findings are suggestive, but the workup turns out negative. So the important thing is to have a high index of suspicion after even defining the case definition, because some of the times we might not get a blood culture or a definitive clue to this. Once confirming the outbreak, the first thing we need to do is to form a team if you don't have one, or if you have an HACC or an infection control team in your unit, so which could consist of doctors, nurses, and HACC people, we need to call for a meeting. So this is an example of how HACC team has actually grouped together and probably discussing how this Acinetobacter has spread in the unit. And we know with all the WhatsApp and the mode of communication, which has become very easy, we can rapidly, disseminate the news and maybe call for an immediate meeting, and also tell the other consultants and other healthcare workers in the unit that we are possibly dealing with an outbreak. We can have a rapid review of literature, which can have which can be with the similar outbreaks across NICU, which can be found in this website. This is a very useful website where if you're looking at outbreaks in any ICU setup. This is www.outbreak database.com. In this database, all the literature of the outbreaks which has been published till today are actually being given. We can navigate through the organisms or even the setting of interest. Here we see the collection of Acinetobacter outbreaks published in the literature over years. So once we get through this literature, we will know, okay, probably we are dealing with similar kind of situation, and this literature search can also help us probably formulating a solution also. So in that sense, this website is very helpful. So with this, we need to get to the bottom. We need to see why this baby probably has infection or why the other babies got infection. We need to look at interest factors. If the baby was intubated, was on mechanical ventilation, was there any umbilical catheterization done for the baby, or was the baby receiving TPN apart from prematurity? We also need to look at environmental surveillance. So if you have not one, probably we would want to do a surveillance. And the other most important thing which probably help us practically is to perform a root cause analysis. So we need to get to why this happened and how this happened. And probably this will happen with the team members contributing to the points. So here is an example of root cause analysis of each outbreak which we do in our unit. which is there onto your right side. So with this, we go on to the step 3, which is to study the event and start the first control measures. So once the outbreak is confirmed, we need to adopt immediate control measures because we don't have time to waste here. We need to proceed for further investigation and probably start writing a report on this. So how do we rapidly identify the cases? We need to do a focused clinical examination because most of the time we won't be able to get a definitive lab evidence. So focused examination is the key, as Dr. Anita was saying. In all setups, examination is important. Keep a low threshold for suspicion of sepsis and investigate it, and send cultures of all babies. In our unit, we have a practice of sending rectal swabs or skin swabs of all the babies if we suspect any outbreaks, and we do it routinely every week with the help of HSCC to know if any baby has been colonized, if not infected with the similar case. Coming to the case, so with this we started doing this rectal swabbing. We found out 3 cases and 2 rectal swabs were positive for this Acinetobacter. So this helped in keeping track of and also we need to keep a track of root cause for the source of root cause for the source identification. So this helped in probably segregating the babies who were actually colonized, and also got us to know what was the root cause of it. The next important thing is to prevent further spread. We need to strengthen asepsis routines. So there is no substantiation for a good hand hygiene practices in the unit. We need to strengthen it. We can also do cohorting. We can do isolation. We can also do barrier nursing. So the concept of cohorting, I'm sure most of us know. If you see in this slide, you have an index case which probably has exposed the various other index cases. So cohort them all together. Make sure the other cohorts are not probably are exposed to the index case again, so that you can contain the disease there. And here is an example of cohorting an influenza epidemic in one of the South Korean hospitals. You can see influenza patients have been cohorted in an isolation room over here. Since the isolation facility was probably not too much, one of the cases had a barrier where it was separated from the other beds. So we can do this improvisation within our NICU. If we have an isolation room or if we have adequate space, the job will become easy. If we don't have one, probably we'll have to create these kind of barriers or isolation rooms within our NICUs. So this is an example of our own unit, where you can see we have so once the outbreak is once we identify the target as well as the babies who are exposed to the target cases, we separate them with an area which has a separate wash area, and the nurses over there will take care of only those babies, and those nurses will not take care of any other babies who are not exposed to the cohort. And it's also preferable to have a separate exit and entry to that space. Here you can see in our unit, so is an example where you are actually seeing a separate exit. So entrance and exit will not happen in the common area. So this kind of has a cohorting where the cases won't mix up and there won't be any chances of having cross contamination between the cases. And we also should be mindful of disease specific isolation recommendations. So if we are suspecting certain kind of diseases, we need to know what are the infections which require standard precautions, what are the infections requires contact precautions, which are the infections which require droplet precautions and airborne precautions. So depending on that, we need to have a plan of isolating, cohorting, or probably even take airborne precautions depending on the infections. So immediate control measures for an outbreak. I mean, even before we plan all this, so we need to have these things in mind. If the transmission type suspected is cross transmission, so there should be patient isolation and barrier precautions. If we suspect hand transmission, improvement in hand washing and cohorting. Airborne agent will require appropriate ventilation. Agent which is present in the water or a waterborne agent, we need to immediately check the water supply and all the liquid containers. If it's a foodborne agent, we need to look at the food which is at risk. So once it is done, we need to determine the source, define and test a hypothesis. A hypothesis in the sense like, so how did this bug got entry into the other bed, or how did this organism traveled so far to infect another baby to affect another baby. So we need to always be having that detective lens when we look at all this. So we need to look at the cluster of places where it has happened, trace the part which are the babies which probably have have got infected, and trace the movements of the healthcare professionals about where all, which all surfaces they are likely to touch after touching those babies. The likely source of infection could be IV fluid preparations, TPN preparations. It could be incubators, X-ray plates, drugs, humidification chambers, stethoscope, ventilator circuits, tap water, soap solution, mobile phones. All these have been shown to be good sources of infection, which can keep spreading the infection, causing outbreaks. And the other most important thing is the health workers' hands. So as Praveen sir was rightly saying, the hands, if hand hygiene, if we can take care of very well, probably we can stop 90% of infections, 90 to 95% of infection in our ICUs. In our case, the outborn had Acinetobacter, so that was the first source. So we got to know that was the baby was an index case. So we looked at all these sources, and we also had in mind a disposable respiratory equipment, which was found to be used for other babies. We also suspected that this could be one which could be a likely source of contaminant. So we also should be mindful of organisms, because particular organisms can have particular kind of transmission rates. They will have their preference sources of infection and all. So you, like for example, Staphylococcus, the cultures where we can look for is the skin, nasal smear of NICU people, and these are very common. We can have Pseudomonas, which can harbor in povidone iodine, humidifiers and nebulizers. Candida can be transmitted by TPN and IV fluids, and Klebsiella enterobacter could be present in the stool and oral secretions of neonates and etc. So once we know the organism, we also probably can look into the common sources and start eliminating them, or probably start looking at them as a possible source of contaminant. So for example, I'm just to give an example about MRSA. So the source identification will be done by giving nasal swabs of healthcare professionals, or probably even the mothers. We take contact precautions here, and if the baby is positive, it is isolated, and sometimes we need to screen the parent also if the healthcare professionals cultures come negative. And we also can formulate a solution for this. If any person is found positive for MRSA, nasal mupirocin could be given. So this is an example of kind of looking at the organism, looking at this source, immediately segregating them, and also treating their outbreak. We also need to have an idea about how long these organisms stay once colonized. This just gives this table gives length of survival of organisms in different surfaces. I'm not going to the depths of it. So as you can see, it can stay for days to months. So less than 1 hour to months they can stay. We need to be mindful of this also. So other thing which probably we need to look at is the pattern of spread. So if you can look at this chart over here, so this graph says once there is exposure, you will have a number of cases which probably has increased, and you see that the cases will start coming down. So that means to say, so we can probably approximate the maximum incubation period. So this will be one-time exposure. That's why you have one peak over here, and then it starts coming down. That means to say a thing has come, it has given infection, and it has gone. We'll be very happy with that. So this is how it looks like if it is a common source. So it peaks and it comes down. We thought probably this is a one-time occurrence. So we strengthened the hand hygiene. We thought housekeeping was not happening well. So we thought this probably has eliminated the common source. But unfortunately, our cases, if you analyze it, so it continued for a few days time, and probably took this kind of thing where the peak was not sharp, and it continued to progress. So in these kind of peaks, we need to look at persistent environmental source, or if a person-to-person communication which is happening continuously. And finally, we actually realized that it was a reusable disposable tubing which was the cause of all this. So once we discarded it, so the peak actually came down, or the outbreak ended. So once these steps are done, so we need to go to the step 4, which is implementation of control and prevention measures. And the other most important thing is to communicate findings, like what I'm doing now. Okay, so we need to break this chain of infection. That is more important. So infection control measures that which are core are hand hygiene practices, IV fluid preparations, enforcement of VAP and CLAPSI bundles need to be done. These are the core areas which we need to look at immediately. The other infection control measures will include housekeeping, strengthening of housekeeping protocols, probably looking at food preparation, and also even a small thing like cleaning of diaper area and how is it being discarded. So with this, we can also have infection control measures by relocating, cleaning, and fogging. As per CDC, it is not required routinely. Mopping is found to be superior than fogging. However, it can be done as an epidemic control measures for 1,000 cubic feet. I mean, sorry, for any NICU, for if at all we think of fogging and cleaning and relocating, we can use EcoShield or Bacillus Shield, which can be an aldehyde or a hydrogen peroxide based disinfectant solutions. So another practical aspects which you need to look at little differently during outbreak is to limit new admissions. Maybe you need to communicate it to your obstetric colleagues and see, probably we need to restrict admissions because we probably will run out of space because we are cohorting the babies. We need to avoid transfer of staff because the staff baby ratio is very important to control the infection, and obviously we need to tackle this source. Antibiotic policy may require slight modification in this based on the organism and sensitivity, as Dr. Anita was saying. So we need to have an antibiotics policy in our unit, but when an outbreak happens, when you have high index of suspicion that an organism is probably different from the organism which you are actually seeing in the unit, you might shift your antibiotic policy a little bit during this outbreaks. So in our case, based on sensitivity, other babies whom suspected infection was started on colistin. So as we saw, one of the baby who was started on colistin empirically because the baby showed signs of infection was ultimately saved because the antibiotic policy was shifted only during that outbreak. And this process, we need the measures need to be continued till the last colonized baby is discharged. When I'm saying last colonized baby, I'm not talking about infection. A last exposed baby or a last colonized baby is discharged. This baby needs to be nursed in barrier precautions, have a high index of suspicions for infection, and also have high index of suspicion for infection to the other babies also. These are times where we can install weekly rectal swabs and probably look at colonization and see if it is completely gone from the unit. And the other most important thing is we need to keep meeting frequently, and we need to keep presenting the reports to the unit as well as to the administration to keep them in loop. So this is just an example of a report which was drafted by our infection control team in the NICU, where we had documented MDR Acinetobacter on 3 occasions, MRSA and MDR E. coli, and also on the right side, root cause analysis of these MDR outbreaks. And other most important thing is also not only to communicate within the unit and within the hospital, also to probably increase the knowledge of other units also, and also probably to publish your findings. So we have a guideline to report outbreaks. It's called Orion. It's called Outbreak Response and Intervention Studies of Nosocomial Infection, where you can publish your outbreak measures which you have taken in your unit using these guidelines. So which makes things simpler. So as we all know, prevention is definitely better than cure. Prevention of an outbreaks require active surveillance of infection. We need to have surveillance which is going on in your unit, not just for the not just during the outbreaks. Ensure adequate staff baby ratio. We need to avoid overcrowding. We need to do periodic training and ongoing motivation of all staff, and strict entry level training for all the healthcare professionals. We can also take the help of principles of quality improvement, which will help us motivating the staff and help us to achieve our goals. Sorry, this. And also the other most important thing is to promoting mother's own milk, or promoting reducing the nilpal oral days, which goes a long way in preventing an outbreak or preventing infection in any unit. So to take home the message, we need to keep all the steps in mind. It can be simultaneous, or it can be in any order. So when we are dealing with an outbreak, we need to be swift in acting, because the early we respond, the opportunity of control will be earlier, and we can save many babies. With this, I would like to acknowledge Dr. Bharti, who's a colleague, who's my colleague from St. John's Medical College, who also heads our NICU infection control committee for providing me the resources to prepare for this talk. Thank you.
Nice presentation, Prashant. And about the outbreak in the NICU and how to prevent the outbreak, and how to investigate. And I have one question. There are many doctors who are working in periphery, and they have a national setup. And how to go ahead the outbreaks in periphery, like resource settings. Like they don't have any culture swab, and how to go ahead in periphery settings, like limited source settings.
Yes, sir, that actually is a valid question. So unfortunately, if you don't have facilities for lab investigations, or also lab backup to confirm, most important thing is probably to look at probability of these cases. And I'm very sure in all our SNCU, in at least the SNCUs which have seen, if the all the SNCUs probably has good microbiology backup. And I think everybody should probably move to get quick blood culture to get to know what exactly they're actually dealing with, and probably initiate the outbreak measures in their unit. So sometimes it becomes difficult for us to contain an outbreak without knowing what we are actually dealing with. So for example, if I'm dealing with an MDR bug, my antibiotics, this one would change definitely. If I'm actually dealing with Pseudomonas, I need to know what probably are the sources of infection, so where I can test. So I think even in periphery, I think we need to involve microbiology department or microbiology lab in giving us what exactly the organisms that they will help in probably getting the blood cultures from the index case. They also probably help in surveillance of the environment. Suppose if you don't have anything, so as I said, relocation and probably fumigation in an appropriate way probably help in eliminating the source of infection, and then they can restart it. But I feel blood culture should be done in any ICU.
Thank you, sir, for the wonderful presentation. There's one question from my side. Do we need to restrict new admissions to the NICU greater than ongoing corporate sector? Or do we need to accelerate the new admissions?
Yeah, if I heard the question correctly, I heard how to restrict admissions or how to cohort them. Is that correct, sir?
Question was, do we need to allow admissions in a unit where there is an outbreak identified, right?
Yes. Yes, I think it's a valid point in a peripheral place where you probably won't have any other place to go. If you can restrict, because you know that an outbreak is going on once your outbreak is contained, in the sense that if you have implemented the containment measure, at least if you have cohorted babies who are exposed to the outbreak, I mean the target baby, I think you can continue to take. But this outbreak management probably will take up a little bit of space as well as human resource, which will hamper the care of normal babies, which we need to keep in mind. So once we know the organism and once we know the mode of transmission, and if we can tackle the source, I think we can continue your rest of the NICU, leaving alone the babies who have been exposed to the index case.
Thank you, Prashant. It was a wonderful presentation. I just remember your report, what you saw. I had discussed that with Suman Rao Madam earlier. Madam told me that if you guys could identify the source from water tank up, which it was fungi, probably one of the times when there was outbreak. In peripheries like us, where medical college, we have two separate ICUs, NICU and inbound and outbound. It will be really difficult for us to restrict, because that is the only place where the newborns come from. District hospital as others. What do we end up doing is we have partitions in Neuro and NSU, and we try to cohort them at one place with two staffs who are them with them. And the new admissions definitely will restrict, but only the necessary admissions will be done. And what is your mode of preference for blood culture? You guys use BACTEC there, or how is it like?
Yes, it is. It is BACTEC.
BACTEC, I think that would be that one thing I think we can highlight, because BACTEC gives sensitivity and the specificity very clearly, and you can know as early as 6 to 8 hours if the any anti-organism is growing, and Amstin can be known as early as 12 hours. I guess that will be easy in BACTEC method as well, right?
Sir,
yes, Dr. Sidhu.
Like in Hollywood, the hormones can be taken swab for how many months? How frequently?
Routine swabbing is not probably going to help you, but in a setting of an outbreak, I think swabbing your warmers or any source which you think could be a potential will definitely help, sir. But there is no recommendation for routine swabbing, disinfecting the areas when the baby goes out is actually very important.
Do you guys regularly fumigate or something of that sort?
No. So we actually don't regularly fumigate. So only when there is necessity, like these kind of outbreaks, we do it.
Actually, MD days, I think we used to do in our NICUs. I mean, it was 5 to 6 years earlier. The concept was to fumigate every 15 days or so. I don't think so. It is recommended right now, unless and until you identify an outbreak. What do you say?
No. Yes, totally agree.
Thank you, Prashant. It was a wonderful talk. We request you to stay back to the inauguration program. Over to you, Dr.
Thank you.
Good morning, everyone. Welcome to you all to Neonatal Sepsis CME, conducted on occasion of global hand washing advocacy. Hand washing day is celebrated on October 15th every year. And the importance of hand washing, we all know as healthcare workers, but this pandemic has made sure that even the common people are aware of the hand washing importance. Now I welcome all the dignitaries onto the dais. Dr. S. Patil, sir, President of the event, Vice Principal, BLDE University. Welcome Chief Guest of the event, Dr. R.M. Mukherjee, sir, Medical Superintendent. Guest of honor, Dr. Ashok Reddy, sir, Chief Medical Officer. Dr. Organizing Chairman, Dr. S.S. Kalyan Chandra, sir. Introduce Master. Organizing Secretary, Dr. Vijayapura, sir. Now I request Dr. S.S. Kalyan Chandra, sir, to welcome.
Very good morning to everyone. I welcome you all for today's Neonatal Sepsis CME being organized on the occasion of and Hygiene Awareness Week of this year. First of all, I would like to welcome our President of today's inauguration, Dr. Shri Patil, sir, Vice Principal Academics, Professor of Pediatrics. Sir consented to preside over this function despite of all his busy schedule. I welcome you, sir. I welcome Dr. Rajesh Munungi, sir, Medical Superintendent, BM Patil Medical College Hospital and Research Center. We all know that we are expecting NAC inspection very shortly, and all our authorities, including medical superintendents, are very busy in the preparation. Still, sir consented to be the chief guest for today's function. I thank you and welcome you for this. I also welcome Dr. Ashok Tardi, sir. He's, I welcome you, sir, for today's function. The delegates, my colleagues, postgraduates, nursing staff, and all the students, and all the for today's function. I also welcome all the speakers who have joined us to the virtual mode for today's function. That is Dr. Anita ma'am, Dr. Prashant sir, Dr. Praveen Nansal sir, and Dr. Patil sir, who have joined virtually. I also welcome all other delegates who have joined virtually this CM. Thank you all and all. Welcome you all.
Yes.
Already inaugurated session by what is that?
Sir, so good sir, very sir, please. Anil sir, Pulkar sir, okay sir.
Request Dr. Ashok Karve sir to answer.
Morning, everybody. I was surprised when I was asked to speak on this pediatric CME. I'm the most pediatric fellow in this. I don't know what to speak, but what I understood is that curtailing of infections in pediatric cases or neonates, hand washing would be the best. And I am aware that I have trained all of the postgraduates regarding hand washing and other measures for hospital infection control. So, curtailing of infections is a major process for treating the babies in NICU. All this while you have heard regarding this sepsis control in what they are doing in NICUs in the St. John's Medical College. What I have learned was one extra thing they have in their NICU is that separate hand wash area and kangaroo area also they have got separate where they don't mix the incoming babies and the outgoing babies also. So they have a separate pathways for both of them. So I would like to request our medical superintendent and the HOD of the pediatric department and the caretaker of the NICUs to accommodate these washing areas. That would be fine. The major appreciation would be the curtailing of the infections. But all said and done, we all end up once again to curtail infection is by hand wash. So I once again stress all of you, especially the postgraduates and the housekeeping people, to be perfect in hand washing before they touch one baby from the other. So with this, I don't know what to speak more on sepsis regarding babies, but controlling of infection is a mandatory process in the NICUs. And in addition to that, I would also advise to follow the other protocols which may contain the measures of, which may contain the infection of the NICUs. I thank all of you for honoring me with the guest of honor here. I thank all the organizations. I thank everybody for giving me an opportunity to speak on this. Thank you all.
Managing Chairman of this today's CME and Organizing Secretary of and the professors and my dear colleagues and students. I'm very happy to know that this is Hand Hygiene Week and to stress upon hand hygiene week and to prevent sepsis in neonates especially. So this year is being organized by Pediatrics Department. I congratulate all of you on this occasion. As we all know, sepsis is one of the integral part of management, either in adults or pediatrics or in any other branches, clinical branches. So one part is to prevention is definitely more better than ever, as all of you know. So many speakers have stressed upon how to prevent the sepsis. So as a part of that, this hand hygiene is one of the important and foremost things. What I think is to prevent infections at least by 99%. And other measures are there, definitely they will also help. Definitely hand hygiene is one of the important things. And which we should all follow in all areas of health. And I think these deliberations in CMEs, we have various recognized guest speakers. So they will help us, and especially our postgraduate students, to identify, to approach the case of neonatal sepsis, and also help to prevent the neonatal sepsis. And also, I hope that these deliberations will bring the newer innovations or even advances in neonatal sepsis, any other. You all know that we, since last probably 1 decade, 1.5 decades, we have not invented again. That will be the probably a major hurdle for us in treating infections in future. So we all try to prevent the infections. That is our major concern. And also I wish all the doctors or staff who are involved in ICUs to take point and to note this and stress 100% to have a very good hand hygiene and to prevent the infections. I thank the organizing committee for inviting me as a chief guest for today's function, and I wish the function to be a success. Thank you.
Very much, sir. As the rightly said, prevention is better than cure. So we prevent infections in babies with following proper measures and steps for prevention of infections. Now I request Dr. Shri Patil sir to take over the presidential remarks.
When organizing secretary came to me about organization of CME team on neonatal sepsis. As I said, it is a big iceberg. Like whatever you do is all new in this. But really, once we know that what is going new in this sepsis forum is totally different. Gone are the days when we studied, when all of us, most of us, majority of us studied that the probable blood culture is the gold standard. Many things were taken into account about the sepsis. Later on, again, the investigation took up the upper hand where the evidence-based, following these organisms were isolated and probably the antibiotic of choice for the better way of prevention of sepsis. Slowly, the hand hygiene and hand washing has been taken care of. And as rightly, our secretary and Dr. Patil has rightly put the advocacy week of hand wash. But this to sensitize all the medical, paramedical, and housekeeping people to know about the hand hygiene and hand rub. The faculties of today's CME inauguration, particularly about the Dr. Prashant, Dr. Anita, and Dr. Patil from Bangalore. Really had given a very good point. Anita, particularly when she said the things begin right from the placenta, triple I, methodology, and some clinical infections. Praveen, what he said about the breaking of the chain, how the things are taken up. These are really important things which are totally new, and I should really congratulate or back up the NNF who really comes out with new methodologies where we get in adopt these two things, particularly about the what Dr. Praveen has said. And ultimately, Dr. Prashant also commented like we need to end up with an committee or the team. Probably now I think this is the right platform. Since Dr. Sardi and Dr. Rajesh Modi, the medical student, is there. I think it is a time for us to constitute a committee on the advocacy of antibiotic policy, the culture audits, and the antibiogram, all things have to be done. Probably with an expertise or probably with another center where we need to really draw a line, the use of drugs and other things. All being said and done, again, the basic concepts of hand wash and exclusive breastfeeding remain the gold standard. And again, the discussions were very practical, that should we restrict the entry of admissions? Should we restrict the neonatal things on based on weight criteria? Should we restrict the sterilizations? So many things are there. We need to draw a line for all the things where the adequate execution of each procedure is taken care of. That's what we need to know. And again, we have some more lectures from our own faculty, Dr. Shri and Dr. Prakash. They will be talking about the stewardship programs, and it is a need of an hour. And of course, these stewardship programs have to be reviewed every 3 or 6 months, and at least half an yearly. And later on, probably we'll have to discuss, and probably when we interact with other faculties, it is very common pathogen that acidinovector, E. coli, and Klebsiella are common organisms in all our regions, and how we can prevent them, how effectively we can treat. That is what the message has come out from today's speakers. I again congratulate all these speakers who are on roll, Dr. Praveen, Dr. Anita, Dr. Prashanta, Dr. Sham, particularly Dr. Praveen and Anita, who are our, I feel they are our own faculty and our own department and our own team since for last 1 year. They are with us and exclusively very nice, and then I think we should really give applause for all the time with us, coming out with the new advocacies which the NNF brings up. And I think we are very good in training and providing a very best neonatal care for this region. And of course, we need to really update and make a good team about the HICC and the committee. I think we should work with the team and move forward to achieve our best target and make a center a very good center of in one of the that should be the motto of all of us. And probably I think most of the postgraduates are also well benefited with these programs. I again thank Dr. Sidhu for having a very good team-based CME, which would really benefit all the pediatricians and all the faculties and all the postgraduates of our institution. I congratulate him and of course the graduates. Team-based CME and a need, and which is a very unanswered question of the huge iceberg. That's what I would like to say, and I wish everyone a very grand success for this. Thank you.
Very much, sir. We look forward to the progress in our department and the program. Now I request Dr. Sidhu Chandri sir to deliver the
Thank you, sir. Sir, you have been our backbones all the time. We sincerely thank Dr. S.P. Patil, sir, President for the current Neonatal Sepsis CME. As usual, this thought started 3 days back when I went to Patil, sir, and subsequently ended up in his research chamber, sir, said, go ahead and take with you. So without your support and guidance, this would have not been possible, sir. Thank you for gracing the event and making this function a grand success. Thanks a lot, sir. Now I thank Dr. Onati, sir, for the Lord Medical Superintendent. In spite of being a busy schedule and NAC coming up, sir, I agreed instantly with our request. Thank you, sir. We look forward to work with you in the future as well in curtailing this neonatal infections and setting up a antibiotic stewardship committee as recommended by our Lord Vice Principal S.V. Patil, sir. And I sincerely thank Dr. Thirty, sir, who has been our mentor and NSU as well. Thank you, sir, for being there with us and helping us achieve in curtailing our sepsis events in NICU. And I have to thank our talent sir. Every day morning, when I go to him, we'll be thinking that what this guy comes up with this today. And what next? Sir, not now, another month. So this was our program planned as usual because of the hand hygiene advocacy week. Thank you, sir, for tolerating with me and being there with us for all the time. And I have to thank all our postgraduates and team, especially Tanmaya, Tejas, Dr. Shri, Gautami ma'am for being there with us. And I have to thank our speakers, Dr. Praveen sir, Dr. Anita Nangoda, Pradeep sir, who is there to speak, Dr. Jayaprakash sir and Prashant, who agreed 2 days back, and they come up with a beautiful presentation. I think we have learned a lot during this academic session, so that I hope we implement this in the coming weeks. Thank you, one and all, and thanks to all the nursing staff as well who have been with us. Thank you. And definitely the IT department, sorry every time I miss them, especially Chirag and team, and especially Salim, Dr. Anand, especially Deepak Chavan sir for providing the Zoom link. Thank you for coming with us. Okay. Now we'll break for a tea break and we'll join back soon. Let's, if you will start at your tables, please be there.
Now I call upon Dr. Vijayapura, Chief Shri, deliver a talk on antibiotic stewardship in MS.
All right, guys, you can continue running it. You can continue with the snacks process. See, this is one of the important parts of current neonatal management in terms of neonatal sepsis. We call it as antimicrobial stewardship in NICU, or basically how do we define our NICU antibiotics in terms. Because we have been all taught during since our PG days that we are supposed to start first line amikacin, gentamicin, second line triptas, third line meropenem. At times we end up jumping the gun. So how does this come into picture? Basically, why do we need stewardship? I'll tell you what does stewardship mean over a period of time, but you just understand why do we need stewardship as such. We have been observing that there is a usage of broad spectrum antimicrobial in the NICU, which has been because of the emergence of multi-drug resistant organisms, especially gram-negative bacilli, development of invasive candidiasis and colonization with candida. I think you all will agree, presently what we have experienced in our own unit, we have gram-negative bacilli as well in the last week, and development of invasive candidiasis, and we ended up using broad spectrum antimicrobial, especially like Miro, Banco, colistin, and recycling. At times, stage second, I agree, we started once the cultures came into picture, but this is the reason why we need to have stewardship per se. Prolonged duration of empiric antibiotics. We end up giving antibiotics for 14 days, 21 days, in spite of culture being negative. So there is no rule. It is individual consultant based concept. Okay, there will be no unit policy as such. Okay, that results in increased mortality and increased rates of NEC. And as earlier told by Dr. Anita, it even results in cerebral palsy. Usage of antibiotics. So this was the concept which came into picture, antibiotic resistance and the global threat. Like rightly it's said by Patil sir in his speech. Sir said that in the last decade we have not even got a single antibiotic. So we end up using all our current antibiotics. If there is an emergence of antibiotic resistance, we will end up having a lot of problems in managing the babies henceforth. So what is the concept of antibiotics? So antibiotics and oxygen are the most overused drugs in most of the NICUs in our country. I can blankly say that the emergence of antibiotic resistant organisms has been linked to inappropriate use and overuse of antibiotics. So who defines this inappropriate use and overuse? If you ask me if I am managing a case, I feel it's right. If somebody else is managing a case, they feel that is right. So how do you test that? That is where the antibiogram and antimicrobial stewardship comes into picture. Okay. Coming to the data per se, in the complex environment of uncertainty and variation in antibiotic use among the NICUs is quite extremely common. Indian data suggests that this is from 2019 what we have got. 54 to 70% of the babies who are admitted in NICU receives antibiotics irrespective of the need. For example, when I came here itself, we had to start prophylactic antibiotic as soon as the baby came to NICU. Babies there's no problem. It was 6 months back. We stopped using antibiotic and we waited for our CRP and blood culture to come. Right? So it took around 1.5 years for us to achieve that. That takes a long time. But as you see, 70% is a huge number. Even if the baby comes for phototherapy, antibiotic. Even if the baby comes for feed intolerance, antibiotic. So there is nothing of that sort to be followed. Why do we prescribe antibiotics? Why are we worried? Why do we end up giving antibiotics for all the babies? The only reason being, sepsis in the unit doesn't have any specific manifestations as such. We all the time discuss this. If the child presents with lethargy, not getting well, the first thing that comes to our mind is sepsis. If the child has high grade fever, the first thing that comes to our mind is sepsis. So there is an uncertainty in the manifestation per se, and normal physical examination does not rule out sepsis. Imagine a child comes from the post-natal ward to an ICU with hypothermia. What is the first thought? Sir, sepsis antibiotic. That's not so. Yes, let us isolate individually, and no combination of laboratory testing with specific sensitivity to preclude infection. See, we have a test to diagnose sepsis, but we don't have anything to preclude infection. What do we understand by preclude infection? To say that there is no sepsis, there is no diagnostic test as such. Okay. Sorry. Okay, one more thing is we end up using antibiotics even in culture negative sepsis, and a diagnostic dilemma occurs when cultures are sterile but the infant continues to have clinical signs or abnormal laboratory values that could be consistent with sepsis. So this we come across every day.
Blood culture comes sterile, but the baby is still subject. In the sense that they are not getting well to increase activity. So we end up giving antibiotics for them. So there is no consensus on the duration of treatment. If two consultants are managing the unit, you end up one will say 7 days, other will say 10 days. Whom you are going to cover? Mind it, it's not going to cover it, it happens everywhere. So that is where the antimicrobial stewardship comes into picture. Drug used for neonatal sepsis varies among pediatricians. Sorry for the word neonatal, among the pediatricians person. So there is a lot of difference. What is the dilemma person? What we have? What is the risk of missing sepsis or risk of poor treatment? What happens commonly with us? Disease. Are we overtreating or are we missing sepsis? It is interactive man. What do you think? Sister, ಏನು ಅನಿಸ್ತದೆ? ಜಾಸ್ತಿ ಟ್ರೀಟ್ ಮಾಡ್ತೀವಿ ಮಿಸ್ ಮಾಡೋದು sepsis. Overtreating. I think sir will agree with this. That is a poor treatment. But there are certain instances where we had an outbreak when we stop our antibiotic usage. What did we miss there? That we will be discussing subsequently. Okay, because 6 months back we had stopped antibiotic usage for all the babies who came to us. Now down the line, last 1 month we have been having something like outbreak which we can't call outbreak because of the diagnostic dilemma. Okay, coming to the stewardship, what is it? Antimicrobial stewardship is nothing but using the right antibiotic at the right time, at the right dose for the right duration. Not individualized. It is a unit-based policy. For every case, this has to be followed. Right antibiotic, right time, right dose, and right duration. The primary goal of antimicrobial stewardship is to optimize clinical outcomes while minimizing the unintended consequences of antimicrobial usage and thereby reducing the healthcare costs without adversely affecting the quality of care. What do we understand by that? Don't treat the baby based on symptoms and signs and labs. You have to combine everything and come to the concept of usage of antimicrobial stewardship, and that policy should be informed to the unit, not to individualized cases per se. What are the principles? What do they do? The ongoing evaluation of the need of antibiotics, appropriate selection of a regimen, optimization of the dose, route, and duration of therapy. For this, a committee has to be formed which has to sit every 3 to 6 months and assess the culture reports and then take a call that what are the most common organisms. If you remember, in the last month itself, we have isolated around 4 to 5 MRSAs, 1 Centrobacter, 1 Candida, probably. Sorry, one more thing. Enterococcus. Yeah, enterococcus. So that is the dilemma. Where do these come? Because our thing is one mix, they tend to mix with that. That is not quite common. But MRSA has been consistently posted with us in most of the cases, which has been sensitive to vancomycin. So who decides this? Is it one person or two? It is a committee which is constituted by a team, which we will be discussing subsequently. So potential and NICU antimicrobial stewardship team includes an infectious disease physician. In our scenario, we can take help of microbiologist also, a clinical pharmacist who prepares the drug, the concept-based regimen, and a pediatrician, clinical microbiologist, information system specialist, hospital epidemiologist, and a staff nurse. At least 4 members can constitute in our institute as such: a pediatrician, microbiologist, and hospital epidemiologist, and a staff nurse. So they can sit every 3 months. I think we can serve a purpose. What do we do here? Minimum stewardship team. Neonatologist to lead the stewardship in interventions. Pharmacists should help in preparing the doses. There is no standard dosing regime. The doses has to be individualized. Nurse for education and implementation of the program per se. That is how we do it. Subsequently, what is the role of a pediatrician per se? Can help determine which stewardship metrics are meaningful to their case. For example, if you ask Prashant, Anita, or anyone else who is talking, they can speak about their own unit. They can't come and tell us that also you can use a BSN or gentamicin. Or just because Praveen is using meropenem, I can't use meropenem in my unit. Okay, that entirely depends on the microbiome which we define every 6 months or 1 year. That is entirely based on your culture reports and the spectrum of infections every month. That is the reason your mortality rate is very important, because at that time you will know the cost for mortality as well. There you will present your statistics. That is the reason it is done every month. Okay, and he or she should coordinate with the team to have proper data and documentation per se. What are the management strategies? How the team goes about? What do they do? Okay, what they have to do is before starting antibiotics, you have to have a clear-cut diagnostic strategies. For example, most of the NNF members advocate rapid sepsis screening test. What do you understand by that? Anyone of you? What are the components of rapid sepsis screening test? Which we regularly do. Two we don't do in our Lovely. Do we do? Anything else? Total count, yeah. Why do I put this on that? It's total count, absolute total count, IT ratio, CRP. Okay, don't go for FI things. In complete hemogram, you get all four of them. That's more than enough. Right? Among five of them, if three are assumed, you are on the right track, start antibiotics. Okay, starting antibiotics, selecting empiric therapy. How do you decide you want ampicillin, amikacin, gentamicin, or pipras? How do you decide that? I think your sepsis screening test. Okay, mind you, I can say tell you a scenario. A newborn is born yesterday night, AR of 24 hours. Mother has got fever 3 days back. Baby has come to NSC. Do you want to start antibiotics for this baby? If so, which antibiotic? And how do you go on? Which one? How do you go?
Probable cases.
Probable cases, yes.
Maybe in strong suspicion of clinical diagnosis and of course backed up by the investigation. Probable cases in septic, positive, and septic. Those are the cases like they require.
Perfect. Yeah, just be brand them as probable septic cases. In that, you have to start a prophylactic antibiotic, which is empiric for your unit. What I'm trying to say is, this can be decided by anyone else sitting outside, unless until you have your own anti-microbial. As simple as that. Okay, re-evaluating the antibiotic regime. Every 3 months, you are supposed to go back and check whether the organisms are sensitive or not. Till now, that is how you go and approach them. Coming to how do you implement it continuously? You have to constantly educate the team involved, including the nursing staff, postgraduates, and the consultants, that this is our antibiotic policy. Let us keep on. If a baby becomes sick overnight, you can't start Mirabanco and say that because rid of Mirabanco, we'll say in the morning. Now, if you have to put a new antibiotic, please make sure you send investigations, at least CRP and blood culture. Then you have to go for antibiotic change policy. And moreover, in good units, in the sense that 2% decision. If you have to change antibiotic from present. Okay, basically it's a point of discussion. You can't go on one-sided trade. That is how they do that. Okay, then organizing with other NSU quality works, as rightly told by Sir, building a research infrastructure purpose. Basically, you have to keep on antimicrobe developing. How do we implement restrictive pervasive approach? Restrictive is all about making a compulsory rule that you have to follow this. That is how it is approached. Because a lot of people tend to deviate from normal protocol. Whereas pervasive approach, you have to constantly counsel them, do unit audit, you have to represent your data, tell them boss classes. This is how you can modify yourself. That is how we look. How do you monitor? Antimicrobial stewardship programs should develop metrics to measure successful implementation and safety. What are these metrics? As soon as you, for example, if you have started your antimicrobial stewardship in October, by next 3 months, you should come to know how much blood cultures are positive. Your blood culture positivity rate will subsequently come down and the antibiotic usage will come down. There is something called usage of antibiotic or antibiotic days when a baby is discharged. Okay, it should not be more than 40 hours if your unit is really running, provided it's an inborn unit. Okay, so potential safety and quality metric is episodes of ineffective antibiotic therapy, organism or antibiotic mismatch. For example, we tend to start one organism we had, it was Candida. We were hitting on to antibacterials, but baby has grown Candida. So that was a typical example of antibiotic mismatch in the organism, what we were dealing with, right? So that is how you keep on changing or learning new things. Next is proportion of infants receiving appropriate dosing and timing of perioperative prophylaxis. Rates of infections with multi-drug resistant organisms. That is what Prashant discussed just now. Episodes of antibiotic associated adverse events, especially NEC, cerebral palsy, and increased mortality. Okay, duration of treatment for culture negative presumed late onset sepsis. This is what we are giving every day. Okay, we end up giving 10-14 days of antibiotics when there is a culture is negative. So in Indian context, okay, this is what our point of put. Ego, life saving, we want to be like warriors, we want to save every child which comes to us. So we end up giving Mirabanco or whichever you have got. Okay, lack of skilled personnel for stewardship program, lack of EMR, attitude of hospital administrators to curtail the usage of antibiotics. This all comes challenges in implementation of the program per se. Coming to the key message, neonatal sepsis is a challenge for all pediatricians, both for diagnosis and treatment. Antibiotic overuse and resistance is a major global healthcare problem. Stewardship is a need for developing countries per se, because in developed countries they are already implementing. Okay. Thank you. Sure.
Stewardship program. Maybe a decade back, I was in one of the panel discussion in state committee. And other state members. It was a part of the discussion, where the protocol of discussion was take the guidelines from the International National Forum, and particularly the chapter forum, your district, your civil hospital, your own hospital. They take audit the things and all those things. This was very lengthy procedure. As rightly, I think I should admire his talk with the content saying that the stewardship is also restricted to our own center itself. Because probably we do not know what is the growth happening in hospital or a hospital nearby. We do not know. The patient, the child is admitted here, referred here. The first step has to be taken. Of course, we should have a strong concept about the hand wash and other things, and then begin with the EPC approach only. The stewardship program, my concept a decade back was a huge Herculean task, I felt, because this is how we should go with this antibiogram, then take all the drugs, the MIC, the cultures, the culture positivity, the reliability of the report, so many things. I thought it was a very difficult task. But as said and done, a very good team is all that is required, and a very good backup of investigation. So I have requested to give a very strong backup on the culture positivity rates, so that this stewardship program can stand, grow, and survive. Otherwise, the culture, it is difficult to derive a stewardship formula. So this is how, and I think he is rightly put that this stewardship program is for the institution, and probably the nursery growth, what we saw from the speakers, is all same, everywhere same. So this is what the thinking of institutions go along, and we across the we exchange our thoughts like what are the probable growths. This is how the stewardship program has begun, and they rightly put into the program that we can get that, and this could be itself can be a stewardship program to derive so many conclusions on this. Thank you.
I will request Dr. Patil sir, consultant neonatologist, MS Ramaya Medical College, Bangalore, to deliver a talk on developmental support.
Pradeep sir, good morning.
Yeah. I think it's almost good afternoon. So, a warm good afternoon to everyone around. Thank you, Sidhu. Can I just share my screen? I don't know.
Yes, sir.
Is my screen visible?
Yes, sir.
Okay. So, a very warm good afternoon to everyone present there. Thank you, Sidhu, for inviting me. Thank you, Department of Pediatrics, BLDE. For people, I've got very sweet memories of BLDE college because my DNP exams were held in BLDE. And I think it was Dr. Akki sir who was my examiner in Vijayapura. So I got my DCH degree. I got my gold medal in DCH where the exams were held in Vijayapura. So I think the foundation of pediatrics and neonatology was started in BLD. That's what I can say. So I will probably next 15-20 minutes. What I'm going to do is talk to you a bit about developmental supportive care. For people, I was just wondering why developmental supportive care in a CME where we are talking about neonatal sepsis. I think Sidhu would agree with me that no neonatal topic, or off late, I think the neonatology will not get completed till you talk a bit on developmental supportive care, whether you are talking about sepsis in your unit, whether you're talking about a management of respiratory support. You talk about any disease in NICU, I don't think you can treat a baby without giving attention to its developmental supportive care. So it's no more about disease specific. We say it has to be baby specific or baby oriented care. And that is what in simple words developmental supporting care means. So all of us agree, at least for me, from my DCH or from those days to DM and now 16 years post DM, I think we have seen great advancement in neonatal care. I don't think, at least my generation, I have seen drastic improvement in the neonatal care, whether it is form of respiratory support, high frequency ventilations, cooling and whatnot and all. I think we have done a deal of improvement in the last few decades, at least last 2 decades. I said there, it's been a tremendous improvement in the NICU care. But what it has also come out with, it has come with a cost of very high physical and mental stress. Now, a 26-weeker would end up staying in NICU for 3 months, 4 months. It definitely goes through. I think the big cost this baby is paying is having a very high physical and mental stress, which we do not understand. We are so busy treating RDS, we are so busy treating BPD, we are so busy treating sepsis. We just forget that there is a soul who's lying there for 4 months and undergoing or experiencing all the kind of physical and mental stress. I think 10 years back, we were least worried. We just want the baby to survive. We didn't bother about the babies having RDS or babies not having RDS. We were least worried about is all we were interested in knowing is this baby should survive at any cost. And we did not pay any attention to the baby per se. We forgot to even acknowledge that the baby is undergoing stress. I think of late, I think last few years, people have been talking about developmental supportive care. And I think slowly all of us neonatologists have become a little more sensitive to this developmental supportive care. And basically what we are talking about is a negative sensory inputs that the baby faces in the NICU. So this is where I think we need to sensitize not only ourselves, our healthcare, our nurses who are working in NICU to be little sensitive, saying that there is a soul who's lying there. In addition to all the disease, he has his physical and emotional needs. I think that is what we need to understand. When the baby is in the womb, there is a positive sensory stimulation. What do I mean by that? I think once the baby is in womb, let us be very, very clear about what is the kind of environment the baby is living in. One, the baby is in a very dark, dimmed light environment. There is no bright lights disturbing the baby. The baby has the only sound that the baby can hear is a maternal heartbeat and maternal voice, if at all, after 20 weeks of gestation. The touch is of the uterus and the gentle rocking that happens with every movement of the mother in the baby floating in the amniotic fluid and baby is gently being rocked. A very sweet, gentle movements that the baby is, no vigorous movements, nobody's disturbing the baby, nobody's holding the baby vigorously. Very gentle movements in the womb. Uterus is holding, almost wrapping up. The baby is in a flexed position. The baby is sleeping peacefully. It sleeps whenever it wants. It gets up whenever it wants. Nobody is deciding when the baby should sleep, when the baby would get up. Nobody is touching the baby and handling the baby. The baby is left alone to do what it is. He's getting beautiful nutrition. He's only smelling the body fluid or the amniotic fluid. He has no other obnoxious smell that has been torturing the baby. He's getting nice amniotic fluid being swallowed. Nutrition is being taken care by the umbilical cord. Completely positive sensory stimulation for the baby to grow, not only physically, the brain is going to grow. The organization happens in a very beautiful way. The baby continues to live in the womb. And let us be very clear, the organization of the womb is happening in the last trimester, last 3 months. The brain is going through an enormous period of development. And this is a time we want a very good stimulation for the baby, a positive sensory stimulation. So why this is important to understand is when the babies come out, now see the drastic difference. A dark, dull environment now compared to this. Completely. So if the baby is born premature, baby is in a nice environment. What kind of sensory stimulation? Purely negative sensory stimulation. Bright lights. The baby was in dark, dimmed environment, suddenly exposed to bright lights. Noise. Baby was constantly hearing only the heartbeat. Baby was constantly hearing only the mother's voice. Suddenly now he is hearing all kinds of funny noises, right from our mobile ringtones to the alarms on the monitors, to the ventilators, to the human voices, to the people shouting, fighting, rounds, probably Sidhu shouting at his PGs. He's hearing all kinds of noises in the NICU when the, and he's just getting too much of stimulation. People are constantly handling and touching him when it's not needed. There is constant stimulation. There is absolutely no day and night cycle. The babies come in the day or night. The NICU is very bright lit. There is absolutely no the concept that the baby is going to sleep peacefully. Every 2 hours, somebody comes, handles, does the blood sugars. Somebody comes after 2 hours, gives a feeding. So you look at the complete drastic from a completely positive sensory stimulation to a completely negative sensory stimulation, which the baby faces when they're NICU. What is the impact of this? Sorry? Okay. So a completely negative sensory stimulation is detrimental to the baby's the mental growth or to the brain growth or autonomic system, myelination, everything that we talk about. So I think this is the point. Next 10-15 minutes, I may not be able to go to the whole concept of DSC, but what I want people to understand clearly is the baby is coming from a very nice, good environment, which is a positive sensory stimulation, to a very I would say a negative sensory stimulation. This is where I think we need to sensitize that this baby is going to have a lot of stress. Is this stress good for the baby? And imagine this kind of stimulation for next 3 months, 4 months in the NICU. I think you have a very drastic negative stimulation to the baby's brain as such. So what does developmental supportive care mean? By definition, these are practices that are evidence-based interventions. So it is not just whims and fancy, oh, I do this, I do this. No, these are all been systematically studied. So these are evidence-based intervention and that are known to promote newborn brain and neurobehavioral development. I think I'm making 2 points very, very clear. These are simple evidence-based interventions that promote the newborn brain and neurobehavioral development of the baby in a positive way. In simple word, if you ask me, what does developmental supportive care? It is converting your negative sensory stimulation to positive sensory stimulation. Going back from NICU to in utero environment. This is, if you understand this concept, I think all your supportive care will automatically come to you. I'm going to concentrate on very few aspects of developmental supportive care. If you look at the developmental supportive care, we talk about a healing environment. When the baby is in the center, there's a touch, there's a smell, there's a sound and light. And we are talking about positioning, we are talking about partnering with the families, nutrition, protecting the skin, pain and stress, and safeguarding sleep. This is sort of the flower they talk about, and they are all interlinked to each other. Partnering the family is part of the healing environment. Position handling is part of healing environment. Protecting the scene, safeguarding. So this is a total thing. Now, it might take a whole day workshop to make everybody understand each aspect of it. Probably I'm going to touch only about 2-3 very practical aspects which we have been practicing. And I hope this will be a simple things which does not require loss of cost or money for all the NICUs to incorporate. The first thing which I probably hate a lot is the noise in the NICU. So we all understand our NICUs are very noisy. The NICUs are noisy between 8 to 9 o'clock when the shift changes happen. NICU is noisy between 1 to 2 when the shift change happen. NICU is noisy between 7 to 8 when the shift change happens. And it's like a big market there, and everybody's quiet only when the consultants are around, and the consultant moves are, my PGs are at their peak of their voice, my nurses are saying they're talking to each other, greeting, talking what happened today, everything at a loud voice, and the whole NICU is so noisy. Now, in addition to that, the noises are from our mobiles, from the alarms, from the ventilators, from the equipments, from the way we drag our chairs, we shut our doors, the incubator doors, the NICU doors. I think if you look at it, the NICU is very, very noisy. And if you look at what is the level of acceptable level of NICU, it's supposed to be only 45 decibels. And I'm sure if you start measuring, our NICU will be at least 80 to 90 decibels. The upper limit is more than 65 decibels. You need to take adequate measures to reduce the noise in the NICU. As I told, the baby in the womb is only hearing the maternal heartbeat and maternal sweet voice, and any kind of noise other than that is going to be an obnoxious stimuli for the baby, or it is a negative sensory stimulation. So how do I reduce noise? The first thing is to educate the nurses, tell them the importance of maintaining a quiet and nice environment for betterment of the baby. The babies can sleep better. The baby can have a better, less autonomic disturbance. Because if you notice, suddenly if there is a noise, the babies tend to startle. There's a sudden change in the heart rate. So there's a lot of autonomic disturbances that happen with every noise. So we need to sensitize our nurses saying that noise is not good for the babies. The bobbies are not used for such kind of noises that we talk about. Next is, how do I know what is the noise level unless until you start measuring the noise levels? So what we did is, recently we procured this. We didn't know this is a very cheap equipment that is available. What you see there, decibel meter. I think on Amazon it costed only about some 8 to 10,000 rupees. Once we started putting this gives you a constant. Now there are apps which are available on the mobile. Maybe you can do it every shift. You can keep it on for some time and see what are the noise levels, which are easily, they're all free apps that are available. There's a decibel meter available on the Android and iOS shops. And because those are very individualized, you know, people can't see it. This was a very cheap instrument that we bought around 8 to 10,000 rupees. You put it on the wall and this will constantly keep back, and you can fix an upper limit. Now we have fixed this at a range of 70 to 80 decibels. The moment at the 70 to 80, for 6 seconds, it gives you an alarm saying that you are being above 70 or above 80 decibels. So very simple like this, and so visual alarm for the or the healthcare workers, because they're constantly seeing this. Okay, when they see this and they suddenly feel, oh, the noise levels are too high, they start coming down. Now, whenever the alarm beeps, the NICUs nurses suddenly become alert and see, okay, one of us are talking very loud, we need to be quiet. I think this kind of simple visual alarms in the NICU probably would go a long way in reducing the noise levels for people to appreciate how noisy they have been. Because if you just say, oh, be quiet, they say, no, we are very quiet. They will be talking at the pitch of their voice, but they feel they are very, very soft-spoken people around. Then once you measure and once you start telling them, see, this is the level of noise, we need to come down, take simple measures like, make sure your chairs are all having rubber bushes so that when you drag them, you don't hear any noise. Educate the nurses to shut the doors little gently, keep the alarm levels of your, the telephone lines there, all your mobiles, all the monitors, everything at a low level. So I think this is the kind of thing that you need to do to ensure noise level comes down. And keep monitoring, educate the nurses and keep monitoring them. Tell them, see, this is the noise levels that is not acceptable. And this is a kind of cycle. Educate, you supervise, you again monitor, again come back to them. And I think over a period of time, everyone in the unit will start becoming very, very sensitive. So this is one simple intervention that I would suggest most of the NICUs should do so that you bring down your noise level drastically. It makes a big deal. Even for the healthcare worker, when they work in a quiet environment, the babies tend to sleep better, there is less autonomic disturbances, and the effect of noise on hearing has been a major concern. And once you reduce the noise levels, the hearing also would be better. The second important thing is about the lights in the NICU. I think this is another thing. Everybody expects NICU to be very bright. There are all the lights on in the NICUs because you feel you need to monitor the baby, you need bright lights everywhere, or you need to do procedures. But remember, babies are not used to such bright lights, and the preterm, the eyelids are very, very thin, their pupillary reflex is not there. So even a bright light can be very annoying for the baby because he can't close his eyes, he can't constrict his pupils. Poor fellow has to constantly keep glaring at the bright light, whether it is day or night. We don't even appreciate that. And we have one light on every baby and we feel the NICU should look very bright lit. No, I think we need to get away from that fact and understand that light can be very obnoxious stimuli for the baby. The baby cannot sleep. Even if he closes his eyes, the light still passes through the eyes of a preterm eyes and it still can be very, very annoying to the baby. Whether it will cause eye defect and all, no, that is not a major worry. But a major worry is this kind of light will not allow the baby to sleep peacefully. So one, you need to understand that your lights needs to come down. Nowadays, we are recommending preferably a cyclical. I think Yeah, this is a video, sorry. So what we have done is we have started using a dimmer in the NICU. So the light can dim with every movement. Now you can see that light is completely dim. So this is something which we have done in our NICU. Again, not a very expensive intervention. It just needs a dimmer. You can talk to your the maintenance or the people. They have this simple dimmer which can be converted to all the lights, and you can adjust the brightness of the light. So this is how it should look in the night when there is nothing much happening. Babies are not undergoing procedures. Minimize the light so that the babies are not disturbed. The babies tend to sleep well. Yes, you have to do some procedure. You have to do only at that time you can probably brighten up the light in and around that. Even better would be to have a focused lights which you use only for procedures. Rest of the time, I think we need to appreciate the fact that the light needs to be less. The range is from 10 to 600 flux, but 100 to 200 is what you need to go maximum, and even better would be to do something called as a cyclical lighting. That means have a little daylight, night or evening, whenever you think you feel comfortable, for about 3 hours, 4 hours, 6 hours, do a cycling, dim off the lights, let the baby sleep peacefully. Don't disturb them with the bright lights 24/7. I think the most important thing people need to appreciate is bright light disturbs the sleeps of the babies. You can't have a constant bright light 24/7 into 365 days a year. You need to have a cyclical lighting, whether you want to switch off few lights and keep few lights, or you want to use dimmers. And this is what we have done in our NICU now, using a dimmers, which we can brighten up and bright down the light, and even preferably to do it at a particular time, and so that the babies tend to sleep better. So when not needed, don't keep all your lights on in the NICU. Try to dim them off. Let the babies be at peace. Don't switch it off to the level where you can't see the baby, and that could be dangerous when you don't have enough nurses to monitor. But at least just enough to see the babies. You have your monitors on, but not bright enough to disturb, and definitely not on to the baby's eyes, which could be very, very annoying to the baby. So the second important simple intervention that you can do in your NICUs to take care of your light, and a simple dimmer can solve a lot of your problem. Nesting, I'm sure most of you are doing nesting and swaddling. This is supposed to be one of the proprioceptive stimulation, where the babies they feel as if somebody's holding them. That's the whole idea of having a nest for the nurses, to understand that the nesting has to be around the baby. It should touch the baby. You can't have a nesting very far away from the baby that doesn't serve the baby. It should be touching the baby. The baby should feel as if somebody is holding. That's the whole purpose of it. Is typical to keep the baby in a flexed position, and it is sort of mimic the in utero position where he's wrapped up by the womb. Here, holding the baby or embracing the baby, you are doing this nesting to sort of mimic that kind of a holding or embrace that the baby is supposed to experience. So it should be very, very snugly fitting the baby, and the baby should get a feel of being held. Now, that's the whole purpose of positioning or nesting. Most important, I think the nurses need to understand, our residents need to understand, our thing is, please don't go on handling the baby when it's not. Cluster your groups. If you have to do a blood sugar, you have to give a feed, you have to change the nappy, do it all at once. Move away from the baby, leave him alone for next 1 or 2 hours. Don't disturb it. You do a nappy change, one more person comes and does a blood sugar, one more person is coming and giving a feed. The interns, the postgraduate is going and examine the baby, the consultant is coming and examine the baby. So you can't go on handling the baby, constantly giving an obnoxious stimuli by proprioception, all the time handling, because every time you're handling, you're disturbing the baby, again causing a lot of autonomic disturbance. Definitely not a good thing for the baby's brain. So I think a proper maintained positioning or swaddling, and most important is understand that when it's not needed, please don't touch the baby. Leave the baby alone. Do most of your things by looking at inspection, and cluster your activity. This is, most of this developmental supportive care has to be done by the nurses. If I'm seeing few nurses in the audience, please be sensitive to this. Sensitize your junior staff, sensitize your residents to say that don't handle the baby unnecessarily. We can all touch the baby once, do whatever activity required, move away from the baby and leave him alone for next couple of hours. The next simple thing that you can all incorporate in your NICU. The next most important is the best person to come and give a good developmental supportive care are the parents, and especially the mother. I do not think any one of us can mimic the touch of the mother. None of us can mimic that sweet voice of the mother. None of us can replace the concern the mother has got for the baby. Whatever, however good I am, I just cannot replace a mother. Mother is the most important person who can give the best developmental supportive care for the baby. So please get into the habit. I'm sure all of the units have, but if the units are not, please have a policy, open policy to welcome the mother and tell the mother you are needed in the NICU. Don't make her feel as, oh, please go away, please go away. As soon as a mother comes and stand next to the baby, no, you go away, you will cause infection to the baby. I mean, how can a mother cause infection to the baby? You just need to teach her basic hand hygiene. And please don't be under the impression the mother comes in every time and she will bring infection. No, please, let us be very, very clear. Mothers will never bring infection. It is always our own health workers, or we as health workers are more at a risk than the mothers. So mothers should be encouraged. They should be welcomed. They should not be looking like a guest. Oh, you come, you see, no, you go, because we want to do work. No, I think they should be part of your, care for the babies. And believe me, once you start involving the mother, she will do a much more better developmental supportive care. And early skin to skin, even if you're not doing KMC, first day mother comes, touches the baby, her sweet voice. Remember, the babies have heard mother's voice throughout a pregnancy. Babies do appreciate, do recognize, provided your NICU is little quiet enough, they can hear the mother. And that's the best thing that you can do from the day one itself, that you need to ask the mother to come, touch, hold the baby, talk to the baby, stay some time with the baby. That's a beauty that the baby will appreciate. The mother's sensitive touch. She will touch the baby very gently. She will speak to the baby. I tell the mothers, please speak to your baby. He can hear you. So this is what you need to do, an early skin to skin contact. If I have to summarize all the developmental supportive care into one, I think one single most intervention that you can club all your developmental supportive care is kangaroo mother care. How? One, what happens to the baby's touch? He's being touched very, very gently by the mother. And what they say is every breath of the mother, he's moving up and down, gentle rocking of the baby. The baby is swaddled. Look how the baby is being held by the father. Look at it, how nicely he's holding the baby. He's cuddling the baby. So proprioception is taken care of. Position is taken care of. Who's handling the baby here? Is somebody disturbing the baby? Nobody's disturbing. That comes to minimal handling. Baby is smelling. Only the mother or father's thing. He's not smelling any other alcohol-based hand rubs or soaps in our hand. He's only smelling the mother's chest or mother's breast milk, which he loves. So that smell has been taken care. Position has been taken care. Swaddling has been taken care. Mother speaks to the baby softly. Whenever you see the babies in KMC, you'll be saying, oh, Muddukanda, and she'll be talking to the baby. She's speaking to the baby. The baby is hearing mother's voice. So voice has been taken care of. The baby has been swaddled and kept inside. The light is not hitting the baby's eyes directly. So light is taken care. Noise is taken care. Position is taken care. Proprioception is taken care. Mother is talking to them. Gentle, vestibular is taken care because there is a gentle rocking. There is no, vigorous shaking. With every chest movements, the baby is being gently rocked. I think if we can put the baby onto the KMC, whether it's a father or a mother, I think you have done a great deal. Or, it is like a summary of all the developmental supportive care put together. If you ask me what is a single thing that I can do to take care of all of them, is put the baby into the NICU, into the KMC in the NICU, and keep your NICU quiet. I think you've done most of the activities of the developmental supportive care. So I can go on and on and on with what all I can do, but I think these are the simple things. Noise, light, positioning, and kangaroo mother care are what you can say, a simple thing that you can begin your developmental supportive care with. And I think you can do a great deal to the babies. You can make it as a more positive sensory stimulation. So, I didn't want to take a very long time, but I will probably summarize my talk in saying, first thing is, let us pledge. I think each health worker in the morning need to tell, I think a senior staff nurse, if she's there, NICU in charge nurse, sorry if you're there, a big hi to you. I think when you begin your rounds in the morning, you need to tell your nurses and tell yourself and your nurses, all of us need to take a pledge, saying that, yes, we will make NICU a pleasant place for our babies. We want to make NICU a very beautiful place for our babies. Is the pledge that you need to take yourself, and only when you take a pledge, and it should come within that. Once you take that pledge to make it pleasant, I'm sure you'll do activities which will be developmental supportive care for the baby. Training and sensitization. I could only do sensitization probably last 15 minutes. The training takes a whole lot of, whole day to take care of, but sensitization, at least, I just wanted to sensitize the people sitting there, the residents and the nurses, that it is important to understand developmental supportive care is needed in the NICU. I think even that sensitization is important, followed by training. And if you don't train or if you don't sensitize your health workers in the NICU, you will never be able to successfully implement your developmental supportive care. Parental partnering is very, very important aspect. So make parents a part of your care in the NICU, especially the mother. I'm telling you, she will do a lot more or a much better job in doing a developmental supportive care. So I hope in this last, 15, 20 minutes that I've taken, at least I've been able to sensitize the residents and the nurses about the importance and few small changes that you can make in the NICU to make an NICU a pleasant place for our babies, for all the preterm babies that are going to be in the NICU. Thank you. If I've done that job, I think that was worth the talk I've given for 15, 20 minutes. Sidhu, anything more you wanted me to cover, or this is it?
Sir, you have covered everything, sir. Thanks a lot. It's always a pleasure listening to you.
Thank you.
Nursing staff and the postgraduate students does really well. I think Dr. Gobur sir, our chairperson, would like to share his thoughts. What do you think, sir?
Thank you, sir, for touching the basic aspect, how to improve the developmental aspect of the baby in NICU. I think we require more of from other care chairs rather than ventilators in the NICU. That should be, proportion should be equal. Each warmer or incubator should have one bedside chair so that mother can stay there for longer period with age.
True, sir. True, sir. Pradeep, sir.
Sir.
ಇಲ್ಲ ನಮ್ಮ ನರ್ಸಿಂಗ್ ಸ್ಟಾಫ್ ಇದ್ದಾರೆ ಸರ್, ಕನ್ನಡದಲ್ಲಿ ಸ್ವಲ್ಪ ಹೇಳ್ಬಿಡಿ ಒಂದ್ಸಲ.
ಗುಡ್ ಆಫ್ಟರ್ನೂನ್, ನಮಸ್ಕಾರ ರೀ ಎಲ್ಲರಿಗೂ. ಸೊ ಐ ಥಿಂಕ್ ನರ್ಸಸ್ ನೀವೆಲ್ಲ ಅರ್ಥ ಮಾಡ್ಕೋಬೇಕಾಗಿರೋದು ಏನಂತ ಹೇಳಿದ್ರೆ, ನೀವೊಂದು ದಿವಸ ಜಸ್ಟ್ ಇಮ್ಯಾಜಿನ್ ಮಾಡ್ಬೇಕು, ನಾನಾಗೆ ಈ NICU ಒಂದು 24 ಗಂಟೆ ಕಾಲ ಕಳೆದ್ರೆ ನನಗೆ ಹೆಂಗ್ ಅನ್ಸುತ್ತೆ NICU ಅಲ್ಲಿ, ನನಗೆ ಆರಾಮ್ ಅನ್ಸುತ್ತಾ ಆರಾಮ್ ಅನ್ಸಲ್ವಾ ಅಂತ. ಈಗ ನಿಮ್ಗೆ ಅದು NICU ಅಲ್ಲಿ ಆರಾಮ್ ಅನ್ಸಲ್ಲ, ಆ ಲೈಟು, ಆ ಸೌಂಡು, ಆ ಕಿರಿಕಿರಿ ಆಗ್ತಾ ಇದೆ ಅಂತ ಅನ್ಸಿದ್ರೆ, ಅದೇ ನೀವು ಇಮ್ಯಾಜಿನ್ ಮಾಡ್ಬೇಕಾಗಿರೋದು ನಿಮ್ಮ ಮಗು ಅಲ್ಲಿ, ಒಂದು ಪ್ರಿಮೇಚೂರ್ ಮಗು 28 ವಾರದಿದ್ರೆ 3 ತಿಂಗಳು ಅದೇ ಲೈಟು, ಅದೇ ಸೌಂಡು, ಅದೇ ನಿಮ್ ಗಲಾಟೆ, ಅದೇ ನಿಮ್ದು ಬೈದಾಟ, ಇವನ್ನೇ ಕೇಳ್ಕೊಂಡು 3 ತಿಂಗಳ ಕಾಲ ಕಳಿಬೇಕು ಅಂತ ತುಂಬಾ ಕಷ್ಟ ಆಗುತ್ತೆ. ಸೊ ನೀವುಗಳು ಸ್ವಲ್ಪ ಸೆನ್ಸಿಟಿವ್ ಆಗ್ಬೇಕು. ನೀವು ಇನ್ಚಾರ್ಜ್ ನರ್ಸ್ ಆಗಿರೋರು ನಿಮ್ ಜೂನಿಯರ್ ನರ್ಸ್ಗಳನ್ನ ಸೆನ್ಸಿಟೈಸ್ ಮಾಡ್ಬೇಕು. NICU ಅಲ್ಲಿ ಒಂದು ವಾತಾವರಣ ತುಂಬಾ ಪ್ರಶಾಂತವಾಗಿ, ತುಂಬಾ ಶಾಂತವಾಗಿರ್ಬೇಕು. ಆ ವಾತಾವರಣದಲ್ಲಿದ್ದಾಗ ಮಕ್ಕಳು ಚೆನ್ನಾಗಿ ಬೆಳೀತಾರೆ, ಮಕ್ಕಳ ಮೆದುಳು ತುಂಬಾ ಚೆನ್ನಾಗಿ ಬೆಳೆಯುತ್ತೆ, ನಿಮ್ಗಳು ಕೂಡ ಎಷ್ಟೋ ಡಿಫರೆನ್ಸ್ ಆಗುತ್ತೆ. ನೀವುಗಳು ಕೂಡ ಕೆಲಸ ಮಾಡ್ಬೇಕಾದ್ರೆ ಒಂದು ಶಾಂತ ಪ್ರೆಸೆಂಟ್ನೆಸ್ ಇರುತ್ತೆ. ಸೊ ಐ ಥಿಂಕ್ ನೀವುಗಳು ಸ್ವಲ್ಪ ಸೆನ್ಸಿಟಿವ್ ಆಗ್ಬೇಕು. ಮದರ್ಸ್ ನ ಇನ್ವಾಲ್ವ್ ಮಾಡಿ, ಅವ್ರನ್ನ ನಿಲ್ಸಿ, ಅವ್ರದ್ದು ಮಾತಾಡಕ್ ಬಿಡಿ, KMC ಮಾಡಕ್ ಶುರು ಮಾಡಿ. ಎಷ್ಟು ಬೇಗ ಆಗುತ್ತೋ ಎಷ್ಟೊತ್ತಾಗುತ್ತೋ KMC ಮಾಡಿಸಿ, ಅವ್ರನ್ನೆಲ್ಲ NICU ಬಂದು ಮಗಳು ನೋಡ್ಕೊಳಕ್ ಹೇಳಿ. ತುಂಬಾ ಚೆನ್ನಾಗಿ ಕೆಲಸ ಮಾಡ್ತಾರೆ ತಾಯಂದ್ರು, ಯಾಕಂದ್ರೆ ಅವ್ರಿಗೆ ನಮ್ಗಿಂತ 10 ಪಟ್ಟು ಹೆಚ್ಚು ಕಾಳಜಿ ಅವ್ರ ಮಕ್ಕಳ ಬಗ್ಗೆ. ಸೊ ನೀವುಗಳು ಅರ್ಥ ಮಾಡ್ಕೊಬೇಕಾಗಿರೋದು, ಆ NICU ಒಂದು ವಾತಾವರಣ ತುಂಬಾ ಪ್ರಶಾಂತವಾಗಿರ್ಬೇಕು. ನಮ್ಮ ಮಗುದಕ್ಕೆ ಆ ಲೈಟ್ ಆಗಿರ್ಬೋದು, ಆ ಸೌಂಡ್ ಆಗಿರ್ಬೋದು, ನಮ್ಮ ಮಾತಾಡೋದಾಗಿರ್ಬೋದು, ನಾವು ಮಗು ನಾವು ಹೇಗೆ ಎತ್ಕೋತೀವಿ, ಅದನ್ನ ಹೇಗೆ ನಾವು ಹ್ಯಾಂಡಲ್ ಮಾಡ್ತೀವಿ, ಅಗ್ಲೆಲ್ಲ ಹೋಗಿ ಮುಟ್ಟೋದಾಗಿರ್ಬೋದು, ಇವನ್ನೆಲ್ಲ ಒಂದು ಸಣ್ಣ ಸಣ್ಣ ಚೇಂಜಸ್ ನಿಮ್ಗಳ ಬಿಹೇವಿಯರ್ ಎಲ್ಲ ಚೇಂಜ್ ಆಗ್ಬೇಕು. ನೀವು ಮಾಡ್ಬೇಕು, ನಿಮ್ ನರ್ಸಸ್, ಜೂನಿಯರ್ ನರ್ಸಸ್ ಹೇಳ್ಕೊಡ್ಬೇಕು. ನೀವುಗಳು ನಿಮ್ಮ ರೆಸಿಡೆಂಟ್ಸ್ ನ ಸೂಪರ್ವೈಸ್ ಮಾಡ್ಬೇಕು. ಡಾಕ್ಟರ್ ಅವಶ್ಯಕತೆ ಇಲ್ಲ ಅಂದ್ರೆ ಮುಟ್ಟಬೇಡಿ ಅಂತ ನೀವು ಧೈರ್ಯವಾಗಿ ಹೇಳ್ಬೇಕು. ಮಗು ಮಲ್ಕೊಂಡಿದೆ ಬಿಟ್ಬಿಡಿ, ಏನಾದ್ರೂ ಅವಶ್ಯಕತೆ ಇದ್ರೆ ಮುಟ್ಟೋಣ ಅಂತ. ಸೊ ನೀವುಗಳು ಸ್ವಲ್ಪ ಈ ಎಂಪವರ್ಮೆಂಟ್ ತಗೊಂಡು ನೀವುಗಳು ಮಾಡಿದ್ರೆ ನಿಮ್ಮ NICU ಡೆಫಿನೆಟ್ಲಿ ವಿಲ್ ಬಿಕಮ್ ಅ ಪ್ಲೆಸೆಂಟ್ ಪ್ಲೇಸ್ ಫಾರ್ ದ ಬೇಬೀಸ್ ಟು ಗ್ರೋ ವೆರಿ ವೆಲ್.
Thank you, sir.
Thank you.
Thanks a lot, sir. It's always a pleasure listening to you, sir. Actually,
thank you.
Hopefully the KMC days.
Thank you.
I'll get back to you with that. Thank you for your valuable time, sir. Thank you for attending.
Thank you. Thank you. Thank you, everyone. Thank you. Thank you, Sidhu. Bye.
I request upon Dr. Prakash sir, our Chief Pediatric Intensivist, to deliver the next talk, procedural hygiene practices. I request Dr. Kulkar sir and Ramakrishna sir to kindly share the session.
Welcome all. Thank you, sir. I feel very thankful for this privilege in this CME, which is mainly headed by eminent neurologists, Dr. Aita, Dr. Shri, Dr. Prashant, Dr. Shri, Dr. Patil, sir. So my topic one is procedural hygiene practices. It's more of an interactive session. So you all know that ICU means procedures will be there day in and day out. And ICU means day in and out we usually conduct the procedures. Many procedures, whenever we start the procedure, we should think of there will be a benefit for the patient, at the same time we are going to use a risk for the patient. So that's why the surveillance is one of the most important components of an effective infection control program. So it is defined as systemic collection, analysis, interpretation, and dissemination of data about the occurrence of healthcare associated infections in a definite patient population. So it is nothing but infections that occur more than 48 hours after the admission. So it must be taken into account that different infections have different incubation periods, so that each occurrence must be evaluated individually to determine the relationship between its occurrence and hospitalization. Procedural hygiene practices, all eminent neurologists have been spoken about this in detail. So we do all these procedural hygienic practices mainly to prevent the healthcare associated infections. So what are the 4 major healthcare associated infections which you know? What answers for the audience? Ventilator associated pneumonia. Yeah, central line associated infections. And simple urinary catheter related infections. So one is catheter associated urinary tract infection, that is chronic. Second is central line associated bloodstream infection, clampsing. Third is ventilator associated pneumonia, surgical site infections. So these are the 4 major HCAI which are very much challenging. For all this, we will start with mainly the standard precaution requirement. So mainly hand hygiene. So Dr. Venkat sir, Praveen sir told in detail, very much in detail about the hand hygiene, how to maintain, what are the important steps and all. And of course, personal protective equipments, gloves, face mask, face shield, gown, apron. So these are standard precautions. And steps of hand wash, we don't go into detail. Hope you all thought about all these things. How to hand wash, how to hand rub. Then this 5 minutes of hand hygiene. So one is before patient contact, before aseptic any task, after patient contact, and after body fluid exposure risk, and after contact with patient surroundings. Yeah. So we place the device, say for example, ET2, then the regular basis we need to monitor those things. So monitoring of device associated infections need to be done on the regular basis. The basic indicators required to be monitored are as I told you, VAR, COTI, CLAPS. Active surveillance is required. Just discussing in brief about COTI. I'm not telling everything about the COTI because this is very confined to me. Major prevention aspect. So we just confined to that topics as of now. So the core COTI prevention strategies are first and foremost is hand hygiene. So there is no compromise of hand hygiene. So what usually happens in ICU is the urinary catheterization usually will be given to whom? House surgeons. Okay. The urinary catheterization usually PDs or all of us will is catheterize this child. What happens is house surgeon will not be knowing any steps of all these things. There will be no brand new for all these things, procedures. He don't or she don't even scrub the area with a betadine or whatever. Directly they will take a lidocaine and they will place the catheter. Done. So you introduce the infection. So that's the thing. And I said many times, even they won't wash their hands before doing this procedures. Not even scrub. They will just put the gloves and insert the catheter. So that thing should be avoided, and we should teach them. Unless we teach them, they won't conduct them properly, or you can just tell them to just observe when people are doing performing the procedures. So the first and foremost is hand hygiene, hand wash. And you can see this insertion. Ensure that only properly 10% insert and maintain the catheters. This is the first step where we are failing many times. And insert catheter using aseptic technique and sterile improvements. Okay. Next thing is catheter use. Insert catheters for only appropriate indications. So what happens? Usually any child receives PSU, so just put on a ventilator, insert the catheter, which may not be required in many times. When sepsis, when there is a shock, when you require to monitor the urine, then only you have to place the catheter. Otherwise, when indication is not there, they don't need to put. So leave catheter only as long as it is required. He has recovered from the shock, urine output has been more than 1 ml per kg per hour. Then what is the need? Usually this happens after 2 or 3 days. The catheter will not be required. So when it is not required, better to remove it. And resident considerations, resident means patient. So maintain hydration, bathing, all these things has to be done for the patient. Maintenance, maintain a closed drainage system. What happens in especially in NSU and PSU, we place NG tube instead of police. What happens actually, the closed system may not function many times. It will just come out because of the baby's movements, because of our handling. Usually it will come out. So that thing has to be avoided as much as possible. Maintain a closed drainage system. So maintain unobstructed urine flow. Routine catheter changes and urine use is not required. So just look at this. This is a life cycle of a urinary catheter. We place the catheter, then we will take catheter care should be there. Catheter removal when it is no more required, and catheter reinsertion only if it is indicated. Say for example, a child with a transverse malaria or some GD syndrome who is having urinary stasis. So then only you have to consider reinsertion. In a whole sum, you can just see this is the COTI bundle. It just as it does COTI prevention. Catheter removal, A for aseptic insertion. U use regular assessments. T training for catheter care. I incontinence care planning. So catheter removal, whenever it is no more required, best is to remove that. Aseptic insertion, as we have discussed. So please teach your juniors regarding how to catheterize in an aseptic precaution. And use regular assessment. Regularly, what happens? Just be sometimes the cuff will be deflated, so it will be coming out. Just make sure it is just test daily once at least whether there is a problem place or not. So regular assessment has to happen. Training for the catheter care. So we have to train the residents, you have to train the interns, you have to train the nursing staff. Everyone must be aware of all this care. And incontinence care planning also we have to do. So the last thing is remember no catheter means no catheter associated urinary tract infection. As much as possible, we have to avoid catheterizing the patient. This policy we have been adopting in our ICU. Even a child who has come with a shock and all, if his output is adequate, and we are as much as avoiding as much as possible in our ICU. This is one scenario I just give you. Just tell what it can be. A child who can supply is admitted and is on police custody. Parents notice that the urine in the tube is cloudy. Parents have noticed. Okay. And urine examination showed you sent urine routine. It is showing 30 to 40%. Urine culture has grown equal. So what to do? First, we should say what it is actually. What it can be. Can it be catheter-associated urinary tract infection? Can it be asymptomatic bacteria or simple viral illness? First one's the cloudy so whether it is really infection, so it is nothing but asymptomatic bacteriuria. So just bacterial formation has happened, but there is no sepsis as such because fever is not there. Okay. So what has to be done for this? Just remove the catheter or flush the catheter, and no need to change the antibiotic. We'll continue on the same. This is one more scenario. You can just have a look. Child with severe traumatic brain injury admitted and is on police catheter. On day 4, he developed fever of 104. Urine culture showed more than 1 lakh gram-positive organisms. So now you see, I think you can very confidently say this. Come on, please tell. It is probably no doubt on that. It's a Scotty only because there are serious spikes are there and culture is showing very significant organisms. Scotty, so it has to be treated intensely. Okay, now this is about Scotty prevention. So hope you understand that Scotty and that pneumonia. Now the central line associated bloodstream infection. Again, same thing goes. The hand hygiene is a technique using during catheter insertion and care. Maximum sterile barrier precautions during catheter insertion. Catheter site dressing regimen. There are 4 general categories of central venous catheters, mainly the non-tunnel, which will insert the subclavian inferior tubular veins, peripherally insert in central lines, subcutaneously tunneled and implanted vascular access ports. Okay, the risk associated with central line use, central line are associated with significant risk. Major risk factor for bloodstream infections, associated 2.24 increase in the risk of mortality, increased healthcare costs, follow hospital stays. So one central line is how much approximately? Nearly 4,000 to 5,000 rupees. And single lumen also will cost nearly around 3,000 to 4,000. So before inserting, really just decide whether it is really required or not. So just look at this beautiful chart. There will be high risk for infection and low risk for infection. Where there will be high risk for infection associated with central line? Insertion circumstances. If it is you are doing it in a very emergency situation, child has come in a very short phase. Where sometimes we last week we received one child in the emergency with the burns. So we inserted a simple line in the emergency itself. So which might be actually associated with high risk infections, but we have to test that. There was no other way. So emergency situation definitely there will be high risk. And the skill of inserter, if novice, the person who is doing new, so he will be a risk for producing more infections. Insertion site, femoral vein, actually it is a risk. In adults they consider, but in pediatric, we actually confined to femoral only because of short neck and all these things. The skin antisepsis, catheter movements, if it is multi-element, definitely it's a risk. Duration of catheter use, prolonged use means definitely risk of infection. Barrier precautions are maximal. And low risk will be there whenever it's like insertion technique is elective and skill of inserter is specialized. Insertion parasite supplement means very less of infection. And skin antisepsis 2% chlorhexidine, single event less infection, shorter duration less infection, and maximal barrier precautions less infection. So dissemination of microbes due to central line maybe 4 methods are there. One is intraluminal spread, extraluminal spread, heterogeneous spread, contaminated infused. Just you can have a look at this picture. So where there is a vessel, you are inserting a catheter into the vessel. From there it starts. Actually, the hematogenous spread, one. And second thing is contamination of the catheter. This is a contamination of catheter insertion site dressing contamination. And third is contaminated heterogeneous flush solution, contaminated hubs. Most of the time this will be kept open so that they all invite the infections. So that is why all these hubs and and whatever the where the solutions which we have placed, all these things has to become sterile and contaminated infused. Many times we just take a syringe from the tray and just we put some medicines, which will directly go into the central line. So just your inattentiveness will cause so much of problems for the child. So the practices described in the class C bundle include the first thing is hand hygiene, maximum sterile barrier precautions upon insertion, chlorhexidine skin antisepsis, optimal site selection. But the best is actually supplement or interventional. If it is not possible, femoral is okay. Then daily review of central line necessity and prompt removal of the unnecessary lines. So just this is a simple line bundle, class C bundle we can. So it starts with hand hygiene, maximal barrier precautions, skin antisepsis with chlorhexidine, full body drain, and you can see the transparent dressing should be there, and scrub the hub. Hub means tip of the catheter should be scrubbed. With what? Chlorhexidine. So the many times what happens, they just scrub with the normal saline or something, which is not correct. Okay, it has to be scrubbed with the chlorhexidine. These are the articles required for CVC insertion. As you can see, the artery fossa and trays, and tegader, sutures, all these things. So the personal protective equipment, putting on the caps, putting the shoe covers, and putting on, donning the masks. So these are PPE. So the steps of hand washing, I think you all just once again just will remind. Wet hands with water. Take 3 to 5 ml of soap solution. What happens many times? Our soap solution will be diluted with nicely water. Hardly there will be 10 ml of soap, but 80 ml will be with water. So that won't produce a proper aseptic precautions. Please make sure you use proper soap solution. And palm to palm we have to have back to fingers, interlacing fingers, palm over dorsum, rotational rubbing of thumb, fingertips, rinse the hands with water. That completes the hand wash. So donning sterile gown. What is happening is I am seeing, and I think it might be happening in many MSc or PSUs. Many times we are compromising on these donning the sterile gowns. We just wash the hands. We attempt the LP, we attempt the central lines, we attempt the ICD tubes. This should not be done at all. So the ICUs and NICUs will be properly procured with all these sterile gowns. That is full arm. So and putting the, after wearing the gowns, we have to don the sterile gloves. So once we done that, then identification of the site, and we are going to scrub the site. Cleaning with skin with alcohol, chlorhexidine, iodine-based antiseptics. Draping the patient using sterile towels. So this is again we are facing a challenge in many places, I think. So drapes will not be adequate in many places. So just we'll put one whole towel and we'll finish off the procedure. Ideally, there should be proper 4 cloths should be there for draping the child. So these are the common loopholes which we encounter. Continuation of hygiene practices. That is maintenance. We insert very nicely with all aseptic precautions, but at the next, we don't know what is going to happen the next day for that central line or whatever. So the maintenance is most important. Training the staff. So this is again we are training. We just put the line and we'll push off. Please tell the staffs these are the things which we have done and what you are going to do next. What you have to do to avoid the infections. We have to train the staff. So that's a part and parcel. That's what the policy we have inculcated in our PSU. The person who is putting the central line, we are giving the full responsibility for that person. Suppose if I make some our residents to place the line, they are responsible for taking care of the line till the patient will be in the central line. Training doctors, residents, daily attendance to the practices, daily inspection of the line. So maintenance is most important there. So maintenance of central venous catheters, transparent dressing should be there. Chlorhexidine impregnated sponge, securing ports in the sterile towel. And care of site is very important. Scrub the hub. So what we are doing is like daily and the morning shift times. The first thing he is going to do is we are going to scrub the hub. yeah, he is going to take cotton in this thing and sterilium. So he will be washing 10 centimeter proximal, 10 centimeter distal to the central line. So that thing has to be scrubbed completely. So major adherence to the bundle requires a yes to all of this following. Hand hygiene, yes. Appropriate skin preparation, and there is chlorhexidine and povidone skin preparation agent has completely dried before insertion. And all 5 maximal sterile barriers used: sterile gloves, sterile gown, cap, mask, and sterile full body training. So this is one actual clip toolkit monitoring form. So where we can see the one person will monitor whether he has followed all the steps from beginning from hand wash to the end of the catheter care. So we can make this form and we can make sure the unit is running well in doing the procedures. So the post-insertion care focuses mainly on hand hygiene to all infusion-related procedures, aseptic technique with all catheter and assessed procedures, proper changing of administration sets, changing needless connectors according to manufacturer guidelines, attention to disinfection of needless connectors prior to access, regular side care and dressing changes, daily review of catheter necessity, and prompt removal when it is no longer needed. So ventilator associated pneumonia, I don't have much time, we'll just rush through the slides. So it's pneumonia is one of the 3 most common NCAI, and which occur by mainly aspiration of bacteria colonizing the oropharynx or upper GI of the patient. So how we can prevent the MAP? Adhere to the hand hygiene guidelines, once again same, and healthcare workers should wear a mask or apron whenever soiling the respiratory secretions. Elevate the head end of the bed to 30 to 50 degrees. So every time we keep on telling all these things. So after intubation, you have to elevate the bed to 30 to 40 degrees. Okay. The remove devices such as endotracheal tracheostomy, oro, nasogastric tube from patient as soon as they are not indicated. Perform orotracheal rather than nasotracheal intubation unless contraindicated. Use NRE as much as possible. Perform daily assessments of readiness to wean and use weaning protocols. So avoid unplanned extubation and re-intubation. So many times unplanned extubations will end up in failure. Okay, so again we have to re-intubate. So use a cup endotracheal tube with inline or subglottic suction. Here I just want to highlight one point. So whenever we used a cup endotracheal tube, try to deflate it intermittently. Otherwise, we are going to produce very bad airway complications. So uncomfortable endotracheal is the best one, but at the same time, you have to deflate it periodically. And avoid histamine receptor blocking agents and for patients who are not at risk for developing stress ulcer or stress gastritis. So what is happening? Any patient comes to ICU, we are putting very nice pack bottle for all the patients, which many times may not be required. So perform regular oral care with antiseptic solution. So which one we are using here? Chlorhexidine. So we are making a policy like every patient who is on ventilator has to get a mouthwash or water, teeth wash, everything with the chlorhexidine. So avoid gastric overdistension, remove condensate from the ventilator circuit, change the ventilator circuit only when visibly soiled or malfunctioning, store and disinfect respiratory therapy equipment properly, and educate all the staff. Develop a surveillance system to study the incidence of VAP. So this is the VAP panel in brief. That is oral hygiene, head up, prevents aspiration, reduce ventilation days, sedation holiday or NIV usage, gastric pH should be kept normal, and it means we have to start early feeding. That's the best option. So the infection control policy should be maintained. So that's it, I think. So I once again thank for organizing team for providing me this opportunity, this auspicious CME. Thank you all.
Sir, it was a wonderful and well explained talk. I hope our nursing staff and postgraduates will definitely follow this in the coming days and help us in achieving better things. By this, I conclude the CME program of Neonatal Sepsis. We thank everyone attached to us. Thank you one and all. I thank Patil sir, Patil sir, and all the BLDE pediatric department faculty for being with us during this academic program. Thank you. Thanks again.
for conducting.